There we go. Let's see here. Okay. Hello, everyone. How are we? How's everyone doing? You are the best. Hi, guys. How is everyone doing? No, you don't. Namrita. Oh, is that nice? Oh, Namrita, you thought you had OBGYN, but you have me. Don't you like that? Oh, thank you, Namrita. Look. You know, I kept telling you that I wish I could see you. All right. Colleen sent me a picture. Look, can you see it? Can you see it? Colleen, where are you? Say something. She sent me a picture with her and her little doggy. No one else sent me a picture. So I only know what one of you look like. Colleen, are you there? Where are you, Colleen? Send one. Come on, I thought you guys were going to send me pictures. Send one. Here's Colleen. Here's what Colleen looks like. See? And her little doggy. Thank you, guys. I thought you were going to send me pictures so I'd be able to put a face to a name. Colleen, where are you? You're not even here today. Is Colleen there? I'm so disappointed. Isn't her dog cute? All right. The email, guys, does anyone remember it? I mean, I can say it, but can you type it up? Do you remember the email? I could say it, but that's it. Okay, that's the email. Very good. Thank you. Oh, good. You guys are great. Now, can someone please tell me what you did since I last talked to you? What have you done? Work, Arlene? What else? Rotations, what else? Surgical trauma, okay. Cassandra, I hope you remember did your first Pap smear? Good for you, reviewed the last chapter. Alrighty, surgery at the VA. Alright. You guys are working, you're working hard. When do you get any rest? Never. I want you to rest, seriously. It's important after class. I hope you eat and you rest. Alright? Okay, well just make sure you don't kill yourself, okay? That's important. Alrighty. Alright, can well, I do care, Namrita. In other words, I really feel strongly that you guys gotta rest. You have to rest. You can't work 24 hours a day. You got to get your brain relaxed and do fun things. Right? Right. Okay. Now wake up now when we do our lecture. I'm going to ask you some questions. I want you to tell me. Okay. Can you tell me, can you have melena and hematochezia from upper tract bleeding? Yes. Can you have melena and hematochezia from lower tract bleeding? Yes. Can you have hematemesis from lower tract bleeding? No. Good. You can do everything except backwards. Alright. Tell me the 3 reasons for gastritis. NSAIDs, alcohol, and aspirin. Okay, very good. And when you do an upper endoscopy for GI bleeding, the question you want answered is diagnosis. All right, very good. And when you do a the question you want answered for lower tract bleeding, location, you are perfect. And if you have a patient who has melanoma what's the first thing you put in them? An NG to see if it's upper tract bleeding. And why, when someone has hematemesis, why do we put in an NG tube? To prevent what? Aspiration. Oh, perfect. Okay, let me ask you another question. If you have a kid comes in with a bloody bowel movement, do you do an upper endoscopy and a lower endoscopy and all that? No. You do a Meckel scan. Very, very good. Okay. All right, let me ask you another question, okay? What is the most common cause of bleeding from the nipple? Intraductal papilloma. But you must rule out what? Cancer. Very good. And if you have a fibroadenoma, should you take it out or leave it in and let it grow? Take it out. If you have fibrocystic and you do a big needle aspiration, what are the 3 conditions which allow you to be okay? The 3 conditions. The mass must, what? Go away. The fluid has to be non-bloody, and the mass cannot come. Perfect, perfect, perfect. Okay. Now, I want you to tell me what are the 2 options for invasive ductal cancer? The 2 options. Come on. Modified mastectomy and lumpectomy, radiation, and axillary sampling. Very, very good. Does ductal carcinoma in situ metastasize? No. What is the characteristic of lobular invasive cancer? Bilateral. And what do we call lobular in situ? What do we call it? A tumor marker. Very, very good. All right. If someone is pregnant and has a breast mass, do we terminate the pregnancy? No. For the test, the first thing you do with a breast mass for the test is fine needle. Very, very good. If you have a patient who bumps herself in the breast and there's a lump, can you just ignore it to think it's from trauma? No, you must rule out cancer. Very, very good. All right. If you have a patient who is non-lactating and looks like a mastitis, what do you think that would be? Cancer. Very, very good. If a patient is estrogen positive and progesterone positive, do you do hormonal manipulation? Yes. If someone is positive lymph nodes, do you generally do chemotherapy? Yes. Is breast cancer an aggressive cancer? Yes. Very good. What is overall the best imaging study for the breast? MRI. Very good. You guys are perfect. All right. If you have a thyroid mass, for the test, what's the first thing you do? Fine needle aspiration. What is the most common type of thyroid cancer? Papillary. And if you have follicular carcinoma, can you make the diagnosis by fine needle aspiration? No. If you have medullary carcinoma, what do you think of? What other thing do you think of? MEN what? 2. And if you had MEN2, which would you operate on first, the pheo or the medullary carcinoma? Pheo. If you have anaplastic carcinoma, does that have a 5-year survival? No. Very, very good. Tell me the mnemonic for hypercalcemia. Come on. Stones, bones, abdominal groans, and psychic moans. Very, very good. What is the most common cause of hypercalcemia? Answer. What is the second most common cause? Primary hyperparathyroidism. What's the #1 cause of primary hyperparathyroidism? Adenoma. What's the second most common cause? Hyperplasia. If you have hyperplasia, how many of the glands do you take out? 3.5. When you are with your professor on rounds, do you tell them the mnemonic of hypercalcemia? No. Very good. All right. What is the most common cause of Cushing's? By far. Iatrogenic. If it's not iatrogenic, what's the most common? Pituitary adenoma. Very, very good. All right. If you have 1,000,000 ulcers and you treat it for Helicobacter and they're still okay, ZE. Okay, very, very good. If you see something that says migratory necrotizing something, necrolytic dermatoglucanoma. Okay, see, I can't even remember it. Okay, very good, very good. Okay, if you have a patient with primary hyperaldosteronism, sustained hypertension, is the renin high or low? Low. And what is this called? Cons? Very good. What are the 2 things that can cause secondary hyperaldosteronism? What are the 2 etiologies? Right, renal artery stenosis and fibromuscular dysplasia. Is the renin high or low in those? High. If you have a pheochromocytoma, is the blood pressure sustained or paroxysmal? Paroxysmal. Can you see someone, can you tell by looking at them if they have a pheo? Yes. Does a pheo have to be in the adrenal medulla? No. What is the name of the ganglion at the bifurcation of the organ of Zuckerkantel? Very, very good. That's perfect. Do you have to chemically treat a patient with a pheo before you operate? Which do you block first, alpha or beta? Alpha. Very, very good. And if you have coarctation of the aorta, the notching of the ribs is due to collaterals of what blood vessel? Intercostal. Guys, you don't need me. You know this stuff. Like you're fantastic. Absolutely great. I am delighted. All right. Okay, here we go. We're going to go into my next area, which I really, really like. Pediatric surgery. Okay? Oh, you are kind, Diva, but you really knew the knowledge. The only thing I did was reorganize your brain. Seriously. That's all I did. You knew everything. I just kind of put it in place because, like, I'll show you how I put it in place. Tell me the 4 symptoms of obstruction. Vomiting, crampy, abdominal pain, no gas, and no bowel movement, and abdominal distension. Very, very good. And you know, what word do you think about when you see that? Obstruction. Very good. And the most common cause of small bowel obstruction is? Adhesions. The most common cause of large bowel obstruction is? Cancer. Do you have to evaluate the whole colon for colon cancer? Why? What are you looking for? Synchronous lesions. If you have synchronous lesions, what's the operation? Total colectomy. What are the 5 areas that you can lose blood? Tell me the 5 areas you can lose blood. Chest, abdomen, retroperitoneum, pelvis, and thigh. Very good. And if you have a fracture of the bone in the thigh and they get thrombocytopenic and they get respiratory distress and they get petechiae, what's the fat embolus? Okay. I can't catch you on anything. Very, very good. You guys are perfect. All right. All right. You're perfect. Let's settle down. Let's think. Pediatric surgery. I want to first tell you some rules about pediatric surgery, both for the test and for life. Okay, listen carefully. Okay? In pediatric surgery, you can't figure things out. Meaning, I can help you figure things out in the adult. In pediatric surgery, you can't figure them out because most of the abnormalities are congenital. You got to know them. You have to know the congenital abnormalities. So remember that. You can't figure it out. You got to know the congenital abnormalities. Okay? That's number 1. Number 2, and this is a rule of life. This is a rule of life. When you examine, and all the pediatricians in the audience know this, when you examine a child and the parents are there, you know how normally with an adult you will talk to the person while you examine them? In pediatrics, you never do that. You first find out the history as much as you can. As much as you can. Because the last thing that you should do on your encounter is touch the kid. Because once that kid starts crying, you're done. Everything is done. The parents will give you 1 shot. That's correct time, and you got a short window. So in pediatric surgery or in pediatrics, you ask the parents, you practically know the diagnosis before you do anything. The last thing you do is touch the kid. That's number 2. And now let me tell you the 3rd rule that is for your practice when you see kids. And I love kids, and I love taking care of them. When you go into a room, guys, and you are going to see a child, you always ignore the child. Let me explain. You walk into a room and you immediately look at the child, they will start screaming. They will start crying. What you do, and what I always do, is you walk into the room and you look and start talking to the parents. And what happens is the kid gets jealous. And you're talking to the parents and looking at the parents, and you don't look at the kid yet. And then all of a sudden, the child will start, hey, I'm here, give me some attention. And then all of a sudden, you got them. Guys, this is a really important rule. You never walk in and get direct eye contact with the child straight away. They will start screaming and crying. You look at mom and dad, you talk to them, you sit down, you be nice, and the kid will get jealous, and all of a sudden that little child will start wanting attention from you. Common behavior. Don't forget that. It's really important because you want the kid on your side. Once you examine the kid, they'll hate you. But you've got that window where you can make friends and they will like you. So those are very important rules before we talk about the problems of kids. Do not forget that. I mean it. You take care of kids and they love you, they'll never forget you. And I'll bet some of you guys can remember your pediatricians and can remember perhaps even pediatric surgeons. Can you? All right. And the reason it is because they made a good impression on you. Okay, here we go. He was your grandfather. Jose, your grandfather took care of you? Wow. You're not supposed to take care of your own family. You know what I mean? And I'm going to give you a story later why it's dangerous to kind of take care of your own family. I'll tell you, Diamond, when we talk about something here, today I'm going to tell you exactly why not. And by the way, most hospitals won't let you. They won't, but I'm going to tell you the story, and I'll tell you why it's safe to not do it. Okay, I'll tell you why. Things have changed. And nowadays, if they knew that it was your child, you can't take care of your kid. In other words, if you're in a hospital, I'll explain it to you. Okay, let's start with number one. Number one. A kid comes in, and the baby has excess salivation. And what does the nurse do? Pass a little NG tube. And the nurse finds out that they can't pass that tube very far. And the baby gets an x-ray, and there is air in the GI tract. This is a classic diagnosis of tracheoesophageal fistula with esophageal atresia. Let me say it again. Tracheoesophageal fistula with esophageal atresia. Classic. And you see it. Now, test question. The most common type of and you got to say it together, tracheoesophageal fistula with esophageal atresia is a blind upper esophagus, and the fistula to the trachea is to the distal esophagus and stomach. Let me repeat that. The most common tracheoesophageal fistula with esophageal atresia is a blind upper esophagus, that's why the nurse couldn't pass the NG, and the fistula from the tracheobronchial tree connects to the distal esophagus and stomach. Does everyone understand that? Yes. So now tell me, you got this kid who has a tracheoesophageal fistula and esophageal atresia. What you gonna do? Test question. What you gonna do? Well, Diamond, of course you're gonna do surgery, but what are you... Well, Jose, you do your barium study, and you can do a barium study. The kid won't aspirate. You can do a barium study. Yes, you look for other anomalies. Guys, what are you going to do for the problem? You're going to do surgery. So I'm going to ask you, and this will be on your test, what are you going to do surgically? All right, let me tell you what some of you said and tell you why it's not a great idea. All right, listen carefully. Technically, you could open up the kid, connect the proximal esophagus to the distal esophagus, make it a tube, and divide the fistula from the tracheobronchial tree. You could physically do that. 2 days later, the kid will die. Because, question, and this is a classic test question, Is this kid sick or healthy? Okay, it's the kid's sick, but you have to tell me why. Every time this kid takes a deep breath, where does that air go? Into the stomach. Very good. And when the stomach gets bigger and bigger and bigger and bigger, and the stomach vomits, so to speak, where does that vomit go? Into the lungs. By definition, this child has an aspiration pneumonia. Does everyone understand this? This is really, really important. By definition, this kid has an aspiration pneumonia. So now, you certainly would not do all that surgery in the face of an aspiration pneumonia. So now, you have this kid, you want to feed them, and you want to decompress their stomach so the fluid won't go in their lungs. So therefore, well, you can't put a jejunal tube in because you can't get it to the jejunum. What can you do that's very, very relatively easy? You guys, some of you said it before. A gastrostomy, a peg. That's good. Well, you can't do a peg because you can't get through. You do a gastrostomy. Guys, think about it. You do a gastrostomy in these kids. You can decompress the stomach and feed them. So this is a test question. Guys, this is a classic test question. Listen carefully. If you have a tracheoesophageal fistula with esophageal atresia, the initial surgical treatment is a gastrostomy, and you wait until the kid is reasonably nutritionally good, like a ballpark month, and then you do your definitive surgery. Does everyone this is a classic test question, okay? I'll repeat it again, okay? You can't prevent totally the lung aspiration. But remember, since the trachea is connected to the distal stomach, every time that kid takes a breath, the stomach gets big, and when the stomach vomits, he vomits into his lung. He has an aspiration pneumonia. By definition, he has an aspiration pneumonia. By putting in a gastrostomy tube, you decompress the stomach, you keep it decompressed, and you can feed the kid. You can put in a tube through the gastrostomy that goes in their jejunum. And then, in a month, when the kid is reasonably better in nutrition, then you do your definitive operation. Does everyone understand that? Oh, it's a chemical pneumonitis. You bet it's a chemical pneumonitis. It's an aspiration pneumonitis. Now, they're not eating food, but what's in their stomach? What's in their stomach, guys? Acid. Is that good to have in your lungs or bad to have in your lungs? Bad. 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 Do you understand? Very good. Everyone understand this? Okay. Very good. This is a classic test question. Very, very good. So you first do a gastrostomy, and you wait. You wait at least a month, and you get the kid healthy as the kid could get. And then you do your definitive surgery. All right? Does everyone understand this? This is important. And the final surgery is connecting the blind pouch to the distal esophagus and dividing the fistula. It's not that hard. But you don't, do you do it when the kid is sick or when the kid is relatively healthy? Healthy. Guys, this is a classic test question, but it's also something you got to know, okay? Real, real important. All right, now, let's go to number 2. Oh, Arlene, wait a minute, wait, I want to comment. Arlene said something that's very true. Baby, you go to surgery and you be a cowboy and the patient's asleep. You can connect everything up and get rid of the fistula, and you bet the anastomosis will break down. You bet. And guys, you won't be criticized, you'll be sued, because it's considered negligence. It's considered malpractice. Exactly right, Arlene. Guys, Arlene, clap, 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 clap. Come on, come on. Clap, clap, clap. Very good. Okay, clappy. Alrighty. Okay. You're humble. You're sweet. Number 2. A newborn baby has an imperforate anus. What does that mean, an imperforate anus? What's that mean, guys? What does that mean? It's closed. There's no hole there. Now listen to me carefully, guys. Ooh, Jose, that was well said. Not patent. Jose, you get a little... Let's give Jose a little applause. Come on, that was very well said. Not patent. Okay, the hole's closed. Guys, what you don't do, and I've seen it done, you won't believe this. I've seen someone take a hemostat and stick it through where the opening should be. Arlene, it's called stupid, okay? Guys, because listen to me carefully, test question. Carefully, test question. You do not know if the rectum is that far from the skin or that far from the skin. And that difference is gigantic. And what you do with this child is you transfer the kid to a tertiary care center. That is what they want you to do. Because they want you to be what? Safe. They don't want you to do it. And guys, I've seen it where someone takes a clamp and shoves it up and tries to get in the rectum. Oh my God! You're destroying that kid's sphincter and everything like that. Guys, once you recognize that they have an imperforate anus, you send them to a tertiary care center. You don't take care of it. Alright? I don't take care of it. That has to go to pediatric surgeons who are trained in dissecting and pulling that little rectum down and sewing it to the anus. That's not easy surgery. Okay? Does everyone understand? If there's any question with a child, you transfer the kid to a tertiary care center. And you're doing it so that because you're being what? Safe. 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 Don't be a cowboy with little kids. Alright. Number 3. A kid is born and they're really short of breath. And you hear bowel sounds in their left chest. And you get an x-ray and you see the guts in the left chest. What is this diagnosis? Diaphragmatic hernia. Does it usually occur on the right side? No, because of the liver. It usually occurs on the left side. If you put an NG in the patient, which is a good idea, to decompress the guts, will the tip of the NG be in the chest or the belly? Chest. Very good. That's a classic test question. The NG will be in the chest. Okay. So obviously, the kid needs surgery. This doesn't require a rocket scientist to figure that out. Test question. Do you operate from the chest or the belly? From the belly. From the belly. Is it a hard operation? Simplest in the world. Why? The hole is not big, guys. You pull the guts down and you sew up the hole. You feel real good, and you put the kid in the ICU, and what happens? They die. Test question. Why do these kids die? Say it better, Diva. Hypoplastic lung. What does hypoplasia mean? What does that mean? Does it mean very good, underdeveloped? I like that. I like that word, underdeveloped. I always thought it was a squished lung, but it's not a squished lung. It's underdeveloped. Now listen very carefully, guys. I've always told you that if I took out one of your lungs, like if you had a complete simple pneumothorax, and you were just sitting there, you'd be comfortable. You wouldn't be short of breath. Well, why do these kids get into trouble? Because they have bilateral hypoplasia. That's so important, I'm going to say it again. Bilateral hypoplasia. Do you understand this? So they have immature lungs. You try to ventilate them, they'll get pneumothoraces. You do jet ventilation. This is a disaster. Guys, the vast majority of all my congenital diaphragmatic hernias have died. Oh, why bilateral? Yusra, if you can tell me why, if you can figure it out, you will win the Nobel Prize, and you will be richer than Bill Gates. We don't know. We don't know. It doesn't make sense, does it? Why, if you've got only one lung involved in the squishing, why would it be bilateral? I don't know, but it's bilateral. All right? It's bilateral. So you should try to figure it out, and you'll win the Nobel Prize, okay? All right, you promise me you'll do that? Okay, all right. Guys, you try to ventilate these patients, and they die. And I'm telling you, the mortality is over 90%. I have only had 1 or 2 kids who have survived. Now listen to me carefully, guys. The only way you can make this diagnosis ahead of time is by what? Not an X-ray, an ultrasound in utero. That's correct. Now, if you did an ultrasound in utero, guys, this is going to be unbelievable. But there are surgeons, and there are not a lot of them, who actually can operate in utero. And these are surgeons who train for, oh my God, their training is residency training is 10, 11, 12 years. They use microscopes, they do laparoscopically. It is incredible. And do you know who was one of those surgeons on television? Do you remember? Remember Grey's Anatomy? Remember Dr. McDreamy, his ex-wife, what was her name? What was her name? I can't remember. Addison. Wow, Nata, you know her whole name. Addison Montgomery Shepherd. You must have been a fan. Anyway, guys, you know what was bizarre about Addison? She always had time to go out to lunch, to go out to dinner, to do this. Guys, when you are a surgeon like that, and I've never met one personally who was an in utero surgeon, they are as busy could be. Because let me ask you a question. Surgeons like that, are they in a small town or a big city? A big city. They have to be in a big city, and there's only a few of them truly, not a few of them, but there's not a lot of them in the country, because the training is surgical, is pediatrics, is neonatology, obstetric. I mean, it is such a long training. I've never met someone in real life who is one of those surgeons. Okay, so now let me ask you this question. Let me ask this question, guys. All the women here, you are going to get routine ultrasounds in pregnancy. You are. In the world, does an uncomplicated pregnancy in the world get ultrasounds routinely? No. No, 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 no. All of you guys will get it. In a lot of countries you'll get it, but in the world, someone has an uncomplicated pregnancy, a lot don't get ultrasound. So my point to you is this, that the only way you could make this diagnosis before they deliver is in utero. Has anyone ever seen a diaphragmatic hernia? Yes. Did the children die? Yeah. Has anyone ever seen a diaphragmatic hernia live? I've only told you one or two. And let me just tell you something that's really awful. Surgeons, one of the things about being a surgeon is, generally speaking, we have happy endings. And you know what I mean? We finish a surgery and it's a good thing. And you go out to the family and the surgery went fine and they die. And could you put the kid on? Yeah, we try, Justin. But the problem is, immature lungs are a disaster. We are trying to get better with extracorporeal respiratory institution, but it's terrible. It's terrible. That's why premature kids, have a lot of problems. That's correct. That's right. All right. Very important. So remember, one of the things that they're going to ask you on the test to do with a diaphragmatic hernia is to put in an NG, because it makes a difference to decompress that stomach, stuff like that. Does everyone understand what we talked about? I hate diaphragmatic hernias. I hate them, just for those reasons I told you about. The operation is nothing. It's easy. And they die. Okay? All right. Okay, let's go to number 4 and 5. A child is born with an abdominal wall defect. Guys, don't answer yet. Just listen, okay? Abdominal wall defect. I'm not talking about a hernia. I'm talking about an abdominal wall defect. And their guts, their intestines, are outside their belly. One type goes centrally, and that's called an omphalocele. And the other type is lateral, and that's called gastroschisis. Tell me the huge difference between omphalocele and gastroschisis. Don't say membrane. That's it, Zia. And Justin, a peritoneal baggie. That's correct. In an omphalocele, there's a peritoneal baggie, meaning it's protected by peritoneum. In gastroschisis, there isn't. So why is that important? Oh, I like that, Aminata. The gut outside is naked. That's a good way to say it. Let me explain. Listen carefully. Everyone always thinks that amniotic fluid is like the gentlest fluid in the world. But it's not. It is not the gentlest fluid in the world. It irritates things. So, when you have an omphalocele, in your mind's eye, what it looks like is it looks like a baggie, and then it looks like spaghetti inside. The intestines are nice and thin and beautiful. It looks like spaghetti. In gastroschisis, where the loops of bowel are floating in the amniotic fluid, it looks like sausage. Sausage. Guys, in your brain, I want you to learn it this way. You'll never forget it. Omphalocele looks like spaghetti. Nice spaghetti. In gastroschisis, sausage. They're edematous and thick and ugly. Now, obviously, this makes a big difference in what we have to do, because surgically, we want to put things back inside and fix it. Listen carefully. So, if we can shove everything back inside, and we can close the fascia, and then close the skin, we're home free. If you can't close the fascia, but you can close the skin, that's great. And you're left with what? What are you left with? A hernia, which you'll fix later on in life. Very good. But now comes the hard part. What if you the skin? Well, Arlene said something, and I want to talk about it. She's correct. Are these kids sick or healthy? Why are they sick? And I want you to tell me exactly why they're sick. What do they have? By definition, what do they have? Sepsis, because they have an open abdomen. They have peritonitis. They have an open abdomen. It is no different than, and Laura, you didn't mean eventration, did you? You meant evisceration, didn't you, Laura? Right? Eventration is stretching. Evisceration is open. Laura, you don't have to apologize. You're very polite. Guys, these kids by definition have an open abdomen. They have peritonitis by definition. So, do you send them home? No. Do you send them on the floor? No. You send them where? In the ICU. Do you put them on antibiotics? You bet. Absolutely. They're sick cookies. Now, what do you do with the guts that are hanging out there? I mean, what do you do? What do you do? There, you do a silo. S-I-L-O. Now, let me explain something to you. I grew up in the city of Chicago. I thought when they said a silo procedure, it was after Dr. Silo. Guys, I just didn't know. I grew up I'm a city boy. Can someone please tell me what a silo is? It holds grain. It's on a farm. All that means, a silo procedure, is you cover it. You cover the guts. I don't care what you use. You cover the guts. Anything you want to cover it with, you cover it. You don't leave it open. It's called a silo, S-I-L-O procedure. I always used to think it was Dr. Silo who invented it. No, it's named after a storage container, a grain container. Yes, I'm a city boy. I really am, you know. Remember I told you about playing baseball and line ball in the streets and stuff? A city boy, okay? Now, what you do is you can stretch. You take the kid to surgery and you stretch the abdominal wall. Meaning, remember I told you that kids are real stretchable? Remember I told you that when we talked about crush injuries? Their bones are flexible. Kids are stretchable. They're like basketballs. They're very stretchable. That is why young people look like young people. Meaning, as we get older, what do we get that everyone hates? We get what? We get what? Wrinkles, okay? Okay, you guys want to invent something? Invent a way to get rid of wrinkles other than, and loss of elastin. Justin, you get the gold star. That's correct. We lose elastin. Guys, and you'll win the Nobel Prize, Justin, and you will be richer. Oh, you will really be rich if you can figure that out. Guys, that's why someone, when you look at someone and you haven't seen them for 10 years, even if they're the same height, the same weight, the same everything, you can tell that they're older by the amount of wrinkle. That is correct, Mark. That's why so many people pay so much for Botox and stuff like that. Kids have no wrinkle. Have you ever looked at a kid? They have no wrinkles. They are perfect. You can take and stretch them and they'll go back. Well, what you do is you take the kid to the OR and very quickly, under anesthesia, you stretch their abdominal wall. And in a matter of days, you can stretch their abdominal wall to a point where you get the guts in and close the skin. And that's what you do. That's called a silo procedure. Now, you know what questions you're going to ask me? You're going to ask me, well, should I resect the bowel? Yes or no? No. You'll end up with short gut syndrome. Here comes another question you're going to ask me. Well, why don't I use a mesh? This is a hard question, guys. Not adhesions, not still growing, not loss of fluid. This is a hard question. Let's see if someone can come up with the answer. Nada and Zia, very good. Infection. Is this kid contaminated or not contaminated? Contaminated. You put a piece of mesh in a dirty area, what's going to happen to that piece of mesh? Infection. Absolute. Guys, you cannot use mesh to close it. So that's, everyone always asks me those two questions, okay? You do a silo procedure. Guys, if the bowel is, now, Yusra, I want you to answer your own question. If the bowel is necrotic, do you put back necrotic bowel in? No. You take it out. You know that. You never, ever, 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 ever put something that's dead back in a patient. You know that. But when we say short bowel, some people used to resect the bowel just to get it back in. And they ended up with short gut syndrome. And you don't want that. Short gut syndrome, someone has to be on total parenteral nutrition their whole life. So therefore, guys, we do a very good. I love what you just said. Now you get it. See, if I could see your guys' eyes, then I know that you would get it. That's why I wish I could see you. Okay, so guys, let's repeat what we said here. Omphalocele gastroschisis. For your test, the only thing they're going to say, omphalocele central, gastroschisis lateral. The big difference, omphalocele has a peritoneal baggie, a lining. Gastroschisis does not. Omphalocele, the intestines look like spaghetti. Gastroschisis, They look like sausage because they're soaking in the amniotic fluid. You put these kids in the ICU on antibiotics. They have an open abdomen. They have peritonitis by definition. By definition. If you can close the fascia in the skin, you're home free. If you can close the skin and leave the fascia open, they have a hernia you fix later. If you can't close the skin, you do a silo procedure and you stretch the abdominal wall. In a ballpark week, you can close the skin. Guys, they're both terrible prognoses. They're both terrible prognoses. The biggest problem is gastroscusis. The bowels are like this. In omphalocele, they're nice and little. So which is easier to put back in? Omphalocele, without a question. The only problem is, you said this before, and you're not going to be tested on this, omphalocele can be associated as gastroscusis, but can be associated with a lot of different congenital abnormalities. But they're not testing you on that. They're just testing you on omphalocele and gastroscusis. Does everyone understand the difference? Oh, what do you use to cover the bowel? You can use synthetics, sterile synthetics, plastics. You can use anything. You really can use anything, guys, because why are you covering the bowel? No, I'm serious. Why are you covering the bowel? To try to prevent infection. Very good. Very good moisture. You don't want them to dry out. Let me ask you a question. When I am operating and the guts are outside the patient's belly, you know what I mean, eviscerate the patient, are the anesthesiologists happy or sad? Unhappy. Why? I'm losing heat, I'm losing fluid, and someone said, Arlene, you were correct, I will third space because of the change in environment. That's why the anesthesiologists, guys, always tell you cover up the bowels or put them back in the belly. Always, always, always. That's why we do that. We never leave the bowels outside the belly without a cover. So it doesn't matter what you covered. Do you think you're really preventing infection with a piece of plastic? No. Those bacteria just walk right underneath there and get in. But you're trying to avoid loss of fluid, and this is way beyond step 2. You're trying to avoid loss of fluid. You're trying to keep heat in. That's important. And you're trying to keep third space to a minimum. That was an excellent, excellent, excellent. You guys, that was a great question. All right, guys. One quick question before we take a break. Has anyone ever seen omphalocele or gastroscusis? Yeah. You know what the hardest thing is? The mother. You know, where do they put the baby normally when the baby's born? Where do they put the baby? On the mother's belly. When you have omphalocele or gastroscusis, you gotta obviously that kid is taken away, and the mothers go nuts because they say, "What are you doing?" And it's very, very, unless you had an ultrasound pre-op, which pre-birth, that would tell you that you have this. It's a very, very psychologically difficult thing for the mother and father, but it's more for the mother. You know, look, as much as I love my kids and love childbirth and stuff like that, I'm telling you something. Guys, we cannot appreciate, not even close, what it's like to have a kid grown inside of you and give birth. I mean, seriously, I am so envious of women because it's an amazing thing, and us guys, we watch it, women live it. All right? I mean it, and that's really an amazing thing. All right, let's take a little break, get something to eat, get some coffee, some tea, and we'll be back shortly. All righty. Alrighty. Alright. Here we go. Okay. Guys, some of you forgot the MD after the 210 in my email. Did everyone get it right? Senya has it written down right. Okay. You got it right. Yes? Yeah, Zia? Okay, good. Alright, good. Because I want to hear from you. Good. I want to see your pictures. Alright. Okay, what did you do? Tell me what everyone did. Come on. I want to know what you did. Tea, made coffee. Chocolates. Alright. A turkey sandwich. Sanya, what video did you watch so quickly? Sent you a pic. Alright, you guys, you gotta send me pictures of you so I know what you look like. Appease me. It makes me feel like I'm closer to you. Alicia, you're a fast cook. To make pasta in 10 minutes. Boiled pasta. Jose, images a year later after repair. I got a lot of patients who I operate on who they do okay. They do okay. Alrighty. Let's continue. Okay? Alright. By the way, is there anyone here who is thinking specifically of pediatric surgery as a specialty? Anyone? No. It's a demanding specialty. It really is. Pediatric anesthesia. Alright. Alright. Okay, number 6. Number 6. Let's read that. Mark, you're thinking of it? Pediatric surgery? It's a good field. It's a tough field because you're dealing with, little kids, but it's a great field. Cardiac. Oh my God. Pediatric cardiac surgery? We're going to talk about that when we talk about cardiac surgery. Oh my God. That is a demanding field. Okay. Number 6. A newborn. Oh, I'm going to tell you. Wait. Hang on for a second. When we get to when we talk about cardiology, is cardiac surgery. It's the movie I want you to watch is Something the Lord Made. I'm very serious about this, guys. Something the Lord Made. It was a made-for HBO movie, and it was about Blaylock, Alfred Blaylock, and it was phenomenal movie. And Alan Rickman, if you remember who Alan Rickman is, he's the guy who was the bad guy originally in Die Hard. Oh, he made a great Blaylock. Guys, it's called Something the Lord Made. It is enjoyable, great movie. It won awards like crazy. Something the Lord Made. In fact, I'm going to give it to you as an assignment for you to see it before I come back with you, which I think is Sunday, because I'm going to, I told you, Newfoundland tomorrow morning to be a visiting professor. All right, so I want you to see it, Something the Lord Made. It's a movie about Blaylock, Alfred Blaylock. It's a great movie. All right, make sure everyone watches it. You'll enjoy it, and even if you're not in medicine, if you have a spouse, Diamond, I don't know if it's on Netflix. You can get it. Yeah, you can get it. Yeah, you can get it. I don't know. You can get it. It's very easy to get. Someone look it up on Netflix. I don't think you can get it on YouTube because it's a 2-hour movie. I think it's on Netflix, but I want you to watch it. And if you have a spouse or significant other not in medicine, it's enjoyable even for them because it's just a well-done movie. All right, so look it up on Netflix, Something the Lord Made. I want you to watch it. That's my assignment to you, okay? All right. Number 6. A newborn is noted to have a moist medallion of mucosa which is in between the umbilicus and the pubis, where urine is coming out of it. Now, the only thing that they want you to do is to make the diagnosis of what's called exstrophy of the bladder. Exstrophy of the bladder. And the only thing that they want you to do in this situation is know enough to transfer the patient to a tertiary care center. Guys, I have seen people take a suture and try to sew it up, which is absolutely the wrong thing to do. The only thing they want you to do for the test and your life is to make the diagnosis. You see a medallion of mucosa and urine's coming out, you don't take a stitch and sew it up, okay? You put a bag on it and you send the kid to a tertiary care center straight away to be safe. Do you understand that? Alright, that's all you got to do about that. All they want you to do is make the diagnosis. That's it. And be safe. Okay? Alright. Okay. Number 7 and 8 and 9. I'm going to teach you something in the way that I want you to learn it, so you'll never forget it for the test and for life. Listen to me carefully. You have a newborn, and the newborn is vomiting. Everything they eat, they vomit. They're vomiting continuously. And you get an x-ray, and you see something called a double bubble sign, meaning there's 2 bubbles on the x-ray. Now don't jump. Listen to what I'm saying. The first bubble is the stomach. The second bubble is the duodenum. So, a double bubble sign means you see 2 distensions of the stomach and the duodenum. What is the diagnosis? Oh, wait, stop. Devin, how could you have, if you have pyloric stenosis, how can you have a dilated duodenum? Is the pylorus proximal or distal to the duodenum? It's proximal to the duodenum. So therefore, you know you can't have pyloric stenosis and have a double bubble. Okay? All right. Don't forget that. All right. What is the diagnosis? So you're giving me, Devin, right, you jumped the gun. So take your time, Devin, and think. All right? All right, guys. I don't want you to think about diagnosis, because the only thing that this kid has with a double bubble is an obstruction. An obstruction. Period. You will never make your diagnosis until you operate. So, test question. When someone has a double bubble sign, they have double bubble bowel obstruction. I like saying that. Double bubble bowel obstruction. And that's all you know. Double bubble bowel obstruction. Memorize that. Double bubble bowel obstruction. That's all you know. And you have to operate to determine what specific diagnosis in the double bubble bowel obstruction is. Okay. So we open up the kid. The first, one of the diagnoses that can cause double bubble bowel obstruction is duodenal atresia. What does atresia mean? Failure to, no, Jose, you can't say closed lumen. That is incorrect. That is not correct. It's failure to develop. Failure to develop. Okay? You got no lumen in there. Failure to develop. Jose, that's good. Don't forget that. If you ever say that to an attending, they'll shoot you down. Failure to develop. Alright. So when you have duodenal atresia, it lasts for, I don't know, several centimeters, and then the bowel reconstitutes. Okay. It's duodenal atresia. Alright? So therefore, what would you do for that kid who had double bowel obstruction due to duodenal atresia? What would you do? Okay, now let me take what you said. Yes, you could resect it, and you could connect it back together, but all you want to do is get food from the stomach to the jejunum. And remember, the jejunum is okay. All you want to do is get food there. So what would be a simpler way instead of resecting and doing an anastomosis? Well, a tube, Arlene, that's a... No, recanalization, very good. A gastrojejunostomy, very good. You connect the stomach to the jejunum. And that is the most common treatment for double bowel obstruction due to duodenal atresia. Guys, you don't want to have to do more than you need to do. To resect it and connect it, I mean, you could do that, but it's too much. A gastrojejunostomy. A gastrojejunostomy, okay? I'm going to ask you a test question, a classical test question. Are you ready? A child has duodenal atresia. Tell me, what abnormality will the mother's pregnancy have? Very good. Polyhydramnios. Why? Why? Test question. Why? Right. What happens? Kids can swallow, guys. Where do they absorb the amniotic fluid? In the small bowel. And if the small bowel is blocked by a duodenal atresia, stop saying the child can't swallow. The child can swallow fine. The duodenal atresia prevents the amniotic fluid going to the small bowel, because that's where it's absorbed. That's where it's absorbed. So let me ask you a question. If you had a child with ileal atresia, would the mom have polyhydramnios? No, because the small bowel's open. That's so important, I got to explain it to you again. That's a classic test question. If someone has any obstruction in the duodenum, a kid, the mom's going to have polyhydramnios, because the amniotic fluid which you swallow, the kid swallows, gets absorbed in the small bowel. If they got duodenal atresia, it's not going to get there. But if they have a distal ileal atresia, they got tons of small bowel, and it'll get absorbed. So, a proximal obstruction, duodenal atresia, causes polyhydramnios. A distal obstruction, ileal, no polyhydramnios. Guys, that's a classic. Does everyone understand that? Please tell me if you don't. Alright, very simple. Okay. So, for duodenal atresia, I'll say it again, Diamond. You absorb the amniotic fluid through your small bowel. It goes back into the circulation. If you have duodenal atresia, the amniotic fluid ain't getting there. So the mom will have polyhydramnios. If you have a distal, like an ileal atresia, then you've got enough small bowel that'll absorb it. Amma, you asked a great question. Guys, listen to Amma's question. Oh, well, you can't listen to it, but read it. If you do, everyone always asks me this. When you do a gastrojejunostomy, you know, what happens to the atretic duodenum? Nothing. But you might wonder, how do they get all the pancreatic enzymes and junk like that? How do they get it? Well, it's refluxed through the pylorus, meaning it's not going to come through the duodenum. All the juices are going to come through the pylorus, through the gastrojejunostomy. That's a great question. Everyone always asks that. In other words, how do they get their pancreatic juices and their bile and all that junk? It goes through the pylorus. So it goes kind of backwards. It refluxes. It actually refluxes backwards. Everyone understand that? That's a good question, Emma. Okay. All right. So that's duodenal atresia. Another cause of double bubble bowel obstruction is called annular pancreas. Now, as you remember, embryologically, the pancreas started out with a ventral and dorsal, right? Right? Yes, Professor, I remember. And there was a ring around the duodenum, okay? And normally that ring around the duodenum goes away. But if it stays, you have an annular pancreas, and you have a double bubble bowel obstruction. Double bubble bowel. Get used to saying that. Double bubble bowel obstruction, okay? Okay, so you open the kid up and they've got an annular pancreas. What would you do? Test question. Come on, guys, think. Tell me what you do. Okay, Alicia, remember when we talked about the pancreas? Did I say that the pancreas was your friend or not? It was not your friend. It's your enemy. It hates you. If you cut that ring, if you split that ring, you will get a what? Not a pancreatitis. What will you get? You will get a what? What do surgeons hate? Not a hemorrhage. Not a pseudocyst. Not autodigestion. Guys, if we drained a pseudocyst externally to the outside world, what would we get? Which is bad. A fistula, a fistula, a fistula, a fistula. Do surgeons like pancreatic fistulas? We hate them because they never close. So you don't touch the pancreas. So once again, all you want to do is get food from the stomach to the jejunum. What do? A gastrojejunostomy, same thing. So for double bubble bowel obstruction due to an annular pancreas, you do a gastrojeg. Same thing. Okay? Well, the third cause of double bubble bowel obstruction is called malrotation. Now guys, stick with me. This is complex. Malrotation. Okay? Malrotation. Now in malrotation, the cecum, instead of being in the right lower quadrant, it ends up commonly in the what? Right upper quadrant. Not the left lower quadrant, the right upper quadrant. Alright, now listen. Guys, you got to just listen to me, okay? Because you'll understand it well. The cecum is normally retroperitoneal, which means it has peritoneum in front of it. Okay? So, if the cecum is in the right upper quadrant, the body says, hey, this thing has to be retroperitoneal. So it starts putting peritoneum over it, and it squishes the duodenum. It squishes the duodenum. So, the only thing you have to do with malrotation is you have to cut those peritoneal bands that is making the right upper quadrant cecum retroperitoneum. Does everyone understand what I'm saying so far? I'm going to say it again. In malrotation, the cecum, which is normally in the right lower quadrant, is in the right upper quadrant. The cecum, by definition, is a retroperitoneal structure, which means there's peritoneum in front of it. In the right upper quadrant, when the body starts putting peritoneum up there, it squishes the duodenum, which is in the right upper quadrant. So the only thing that's squishing the duodenum are the peritoneal bands that are making the cecum retroperitoneum up there. Now, the treatment of that is to divide those bands. Now, years ago, guys, surgeons like to have their names on things. So all they are peritoneal bands, but there's a special name that you will need to say for the test. Does anyone know what those bands are called? It starts with an L. Ladd's bands. Guys, Ladd's bands are nothing but peritoneum. But Dr. Ladd described it years ago, and his name stuck. And for the test, they will say you divide Ladd's bands. Okay? That's what you do for malrotation in double bubble bowel obstruction. Now, someone's going to ask me, do we try to sew back the cecum in the right lower quadrant? It never stays. It never stays. Guys, for years, every surgeon has tried to bring that cecum down and suture it to the right lower quadrant. It stays in the right upper quadrant. So, you divide the Ladd's bands. Anything else you should do? Test question. Hard question. Anything else? Vascular supply is perfect, Eva. Decompress, it's fine. It'll all decompress itself. See ya. Sonia, you get the gold star of the day. Give her a hand. Come on. I mean it. Let me explain, guys. Your cecum's in the right upper quadrant. 5 years from now, 5 years from the surgery, the kid gets periumbilical discomfort, and then they get an acute abdomen in the right upper quadrant, and you have no idea what's going on. You know, what's going on? Periumbilical to right upper quadrant? You finally open up the kid, and you find out they have a ruptured appendix. Every time you do a malrotation and divide Ladd's bands, you take out the appendix. That's so important, I'm going to say it again. Every time you do a Ladsband division, you take out the appendix. That's so important. I'm going to say it third time. Every time you do a Ladsband division, you take out the appendix. Guys, this is a classic test question because they will run you through double bubble bowel obstruction, and they will say the cecum's in the right upper quadrant, and you're going to know that it's malrotation. And you're going to see the option divide Ladsbands. And then you're not going to read it. If you're not careful, you'll see they'll say, also do an appendectomy. That's the answer. Does everyone understand that? Does everyone No, it's not Badsband. It's not Badsband. It's Ladsbands. L-A-D-D, okay? But you can call it Badsbands. I think that sounds neat. I like that. Badsband, okay? But it's really Ladsbands. And you will be tested on that exactly. So let me summarize what I said. Everything. It's so easy. A kid is born and they're vomiting. And you get an x-ray and you see a double bubble. Double bubble, stomach, duodenum. And by definition, the diagnosis that you write down is called double bubble bowel obstruction. That's all you can say, double bubble bowel obstruction. You operate. One of the things that cause double bubble bowel obstruction is duodenal atresia. And in duodenal atresia, the treatment is a gastrojejunostomy. One of the other diagnoses that can cause a double bubble bowel obstruction is annular pancreas. You do not cut the pancreas. You do a gastrojejunostomy. The third thing that can cause a double bubble bowel obstruction is malrotation, and you divide the Ladsbands of the cecum in the right upper quadrant and do an appendectomy. And you cannot see if it's duodenal atresia or annular pancreas until you're in the belly. And by the way, what does an atresia of the bowel look like in real life? What does it look like? A piece of spaghetti. Real thin, real thin. A piece of spaghetti. It doesn't look like bowel. A gastrojejunostomy is when you connect the stomach to the jejunum. So there's an opening. There's an anastomosis between the stomach and the jejunum. So food can go from the stomach to the jejunum. It's an anastomosis. That's all. Does everyone understand? Guys, tell me why you do an appendectomy. Tell me why. Nat, I'm going to answer that question in a second. Tell me why you do an appendectomy. Where's the cecum? Where's the cecum? Right, because the appendix pain will go to the right upper quadrant. Very, very good. And you will make a diagnosis late. And you will end up with a ruptured appendix. And the kid could do what? Die. Does everyone understand that? All right. Okay. Now, you asked a very sophisticated question, Nada. You said, when you do gastrojejunostomies on these people, do they get dumping syndrome? Does everyone know what dumping... You're not going to be tested on that. It's third year, step 3. But does everyone know what dumping syndrome means? Let me tell you. People who have dumping syndrome, when they eat, they get cramps and diarrhea. And do you know why people get dumping syndrome? It's because their enzymes and their food are out of sync. Meaning, when your food normally goes into the duodenum, you get your enzymes and it gets digested and goes all the way through. When you have a gastrojejunostomy, and Zia, you're exactly correct about fast transit, you're playing catch-up ball, meaning your food goes real fast into the jejunum, and you're waiting for your enzymes, and they're behind. And so you get massive osmotic fluid into the gut and diarrhea. That's called dumping syndrome. And so people with dumping syndrome have to eat small meals. They have to watch what they eat. I'll give you an example of dumping syndrome in a normal person without surgery. All right, guys. How many here, those of you who have kids, do you take your kids trick-or-treating? Okay. Now let me ask you a question. Be honest. How many of you let your kids eat the candy before dinner? Oh, you all, come on. Guys, when my kids were little, I'd say, you got to eat dinner first. And they wouldn't eat dinner. And you give up after years after year. You just let them eat. Well, when a kid eats all of that candy, and guys, you know, I don't know where you live, but, you know, they come with bags that are this big of candy. And you ever see a kid, one candy after another, I mean, they could eat a tremendous amount of candy. Candy is what? Carbohydrate. Does carbohydrate go slow or fast through the stomach? Fast. Fast. And what happens is they get dumping syndrome gigantically because it goes real fast through. The enzymes don't have a chance to digest it. They get distension, cramping, and diarrhea. Guys, you must have seen this with your kids who eat too much candy and stuff. I'll bet you it's happened to you guys as adults. That, you know, if you, who said, Arlene, you ate a whole bag of Snickers? How could you eat a whole bag of Snickers? Arlene, a whole bag of Snickers at one time? That's a lot of Snickers, okay? You'll get dumping syndrome. So, guys, that's what dumping syndrome is. And yes, this study food. Diamond, it's not good study food. You shouldn't eat candy all. And a Guinness, there you go. That will really make you remember things, right? A Guinness? Okay. Guys, guys, so any patient who has a gastrojejunostomy gets a degree of dumping. Any patient. Any patient. And they have to watch how rapidly they eat. They can't eat huge amounts. So you're correct. You know, that's a good, I'm glad you brought that up. Okay? Does everyone understand? And one more question. Does a distal ileal atresia cause polyhydramnios? No. Does a proximal duodenal atresia cause polyhydramnios? Yes. Okay, guys, these are classic test questions. Very, very good. Okay. Very, very good. Okay. Let's continue. And remember, double bubble bowel obstruction. When your professor says to you and you see a double bubble on x-ray, you can't make the diagnosis. You say double bubble bowel obstruction. That's all you can say. Just like when I've taught you in the adult, vomiting, crampy abdominal pain, no gas or poopy, and abdominal distension. The answer is obstruction. Do you understand? That's so be smart on that. Okay, very good. All right. Number 10. Number 10. You got a preemie baby who gets abdominal distension. Alicia, can I answer your question, by the way? All I'm doing, Alicia, is organizing your thoughts. In medical school nowadays, I get criticized by my peers because I've told you this, they say that I'm spoon feeding. And I tell them, you can't give them a book. You can't give them a book. You just can't say, okay, read it. And I have professors, fellow professors, who believe, they say, oh, Mark, you're spoon-feeding them. Just give them a book and tell them to read it. You can't do that. And I'll just tell you one real quick thing, because you brought it up. My son, who's a professor in England, you know, once in a while he'll ask for my advice, but I've taught him through the years. I mean, he sees what I do with young people, and I tell him, I say, Adam, I say, don't just give him a book to read, especially since it's physics. Go through it. Go through it. And guide them. And can I just tell you one thing? Can I brag for 1 second? Can I brag for 1 second? Please, will you let me? Okay, I have won many times, and I'm very, very honored from the Student's Professor of the Year. My son, and he's only been a professor for a couple of years, he won Professor of the Year. And I was so proud of him. I said, Adam, I said, that's such a wonderful, doesn't it make you feel good? And, you know, he says, oh, yeah, Dad, you know, okay. Well, anyway, okay. So, guys, it's very, very important to structure. I try to structure it in your brain. The way you remember things is to structure them. Think of them in a very structured fashion. That's the way you remember things. You don't remember things when they're hodgepodge. And I'll make you bet that you have gotten lectures from professors where they tell you one thing and skip to another thing and skip to another thing and skip to another thing, and you end up not remembering anything. Am I right? Yeah, like a jigsaw. Well said, Arlene, like a jigsaw puzzle. And you won't remember anything, okay? Always think of it in a structured fashion. You'll never forget it that way. All right? All right. Let's get back to number 10. A preemie, okay, develops abdominal distension and has thrombocytopenia and gets abdominal pain and has air in the portal vein. Guys, listen to what I'm saying. A preemie who has abdominal pain, thrombocytopenia, and has erythema and air in their portal vein, guys, that is classically necrotizing enterocolitis. Has anyone ever seen necrotizing enterocolitis? It's a disaster. Now, can I just explain something to you? One of the questions that always comes up is, why do the kids get thrombocytopenia? Let me explain something to you. In us adults, when we get a bad infection, we get elevated white count, all that junk. Little kids, when they get infected, they get bone marrow suppression, and their cells go down. They get leukopenia, they get thrombocytopenia, and anemia. Has anyone ever taught you that? Okay, listen to me again. This is so important. Okay? You're always looking for elevated white counts and things like that for infection. And that's true, generally speaking. But in little kids, when they get an overwhelming infection, it suppresses their bone marrow. And usually it's an infant. It's only an infant, Alicia. And if you see a low white count and low thrombocytopenia, baby, that kid is grossly infected. And by the way, let me just tell you something. In adults, You don't see it often. But if all of a sudden you see them becoming neutropenic, they are overwhelmingly septic. All right? They are but in kids more than, and I mean, when I say kids, I mean infants. I don't mean, kids 2, 3 years old. I mean infants. When they get thrombocytopenia or neutropenia, they are overwhelmingly infected. And do you know why? The platelets go down first? Because they are the most rapidly dividing. That's why. Okay? They go down fast. Okay, so you got a kid with necrotizing enterocolitis, and you've got him with abdominal wall erythema. You got air in the portal vein, which is awful. What do? You got to operate. And you have to take out all the dead gut that you see. And here's the test question. What is the complication of operating on a kid with necrotizing enterocolitis? If you're cutting out a lot of bowel, what do they end up with? Short gut syndrome. Guys, we don't know why people get necrotizing enterocolitis, but it's a disaster. It's not common, but it's not rare. It happens in preemies. It happens in preemies. And whenever you get a preemie, that's why you got to worry about so many different things when a kid is premature. So when someone has necrotizing enterocolitis, the danger is, well, what is short gut syndrome? Let me explain. Dumping is when the food just goes through you, it doesn't get absorbed. Short gut means you've cut out so much gut that they can't absorb enough nutrients. They actually have a short gut. And that is a big danger of necrotizing enterocolitis, because you see, they're little, and you see areas of the gut that are dead, and you take it out, and you make anastomosis, and you take it out, and you make anastomosis. And sometimes, this is not going to be on the test, but this is something just interesting. Oh, they don't absorb at all. They don't have enough gut to absorb. They just don't have enough gut. Guys, if you have a kid with necrotizing enterocolitis, and I operate on him, and I'm on the fence between taking out the piece of bowel or not, I will do what's called a second look. And I close the kid up, and I take him back the next day and look at that segment of bowel. You do a second look. Have you ever heard of that thing, a second look procedure? Yeah, to see if it's better. If it's bad, you take it out. But guys, I'm telling you, I have operated on a lot of kids who have necrotizing enterocolitis, and they end up with short gut. And when a kid ends up with short gut, you have to put in a port, and they will live. The way they live is they get total parenteral nutrition at night. They work during the day. They can eat, but it's like diarrhea. They can eat, but then at night they connect themselves up with total parenteral nutrition. It's an awful way to exist, but otherwise they can't survive. They can't survive. Does anyone have any patients at all that has short gut syndrome, surgically short gut syndrome? No, Arlene, that's different than dumping. Dumping is when the osmotic pressure is too great and it runs through your gut. It will be malabsorption, but it's not due to physically a short gut. It's due to the enzymes and the food not being in sync together. Does everyone understand the difference? Short gut means it's just short. It's just short. Just short. It's like if I took out your whole jejunum, you'd have short gut syndrome. Okay? Dumping is when the enzymes are trying to catch up to the food, and it never does. Alright? So, that you asked a sophisticated question. That was a sophisticated question. They're both types of malabsorption. They're both types of malabsorption. One is due to out-of-sync enzymes in food. The other is due to just physically you don't have the bowel. You just don't have the bowel. And you're correct, Mark. Dumping can be resolved with eating small meals, slowly, multiple times. That's exactly correct. No one who gets dumping goes to Thanksgiving dinner and eats, when you go to Thanksgiving and you eat, like a huge meal where you can't get up from the table. You know what I'm talking about. No one for dumping can do that. Alright? Alright. Does everyone understand about necrotizing enterocolitis? Has anyone ever seen necrotizing enterocolitis? Guys, it's not uncommon. It is not uncommon. So I just want you to realize that you're going to see this. And these kids, you got to be delicate with them. And a lot of times I will do a second look procedure to save bowel. Now, before we take a quick break, I want to say something, because someone's going to say to me, but Dr. Hill, aren't you being unsafe? Meaning, remember, I always taught you, guys, this is a sophisticated concept I'm going to tell you. Listen carefully to what I'm saying. I've always taught you that if you're on the fence, you always do what's safe. And that is correct. This is the one exception. In other words, think about what I've taught you. This is very sophisticated. You won't be tested on this. You open up the kid, and you have a piece of bowel that's kind of like, well, should I take it out or not? Understand, if it were you, an adult, and you got a gunshot wound, and the piece of bowel was iffy, I'd take it out, because it's a small piece of your whole bowel. But in a little kid, when you've got a large chunk of bowel that could be dead, if I take it out, that kid will have short gut. So in that situation, the safest thing to do, and this is very sophisticated, and way above you, but the safest thing to do is to do a second look operation the next day. Because if you're lucky, and the piece of bowel, like you said, pinks up, you're glad you go like this. You're glad you didn't take it out. You give it a chance. But one of these days you're going to think about what I just said, and you're going to say, isn't that being unsafe? Isn't that being unsafe? Well, it is kind of. If that piece of bowel that I'm watching perforates, kid's going to die. You're correct. So it's a judgment. Guys, this is now you see it's a hard thing. Now, you bet, Arlene, TPN is very expensive. Malnutrition can occur, stunted growth. These kids all have problems. Can I ask you a question? Before we take a break, have you ever seen someone at all, adult or kid, who lives on total parental nutrition? Yeah. Guys, it can also be Crohn's patients. One of the things about Crohn's, Mark, your cousin, oh my. Crohn's patients, guys, sometimes have to have multiple operations, and they end up with short gut. And they end up, needing home total parental nutrition. Now, I just want to say one thing for a second. Guys, you have no concept of what it's like to not have total parental nutrition. Guys, when I was in medical school, we didn't have total parental nutrition. I know that seems like, oh, how could you not have total parental nutrition? Guys, we didn't have it. And people would starve. They would starve. They would die. They would absolutely die. Because, as I told you when we talked about preoperative assessment, nutrition is very, very important. It's very, very important. And I will tell you one final story just to show you. Remember I told you pancreatitis is a bad thing and it's supportive treatment, remember? And you give total parental nutrition as well as other things? Yes? Do you remember I taught you that? Yes? Well, years ago, I had a cousin who was a child psychiatrist, and he was a big guy. He was about 6'7", and he was playing basketball, and he got pancreatitis. And they put him in the house, and in those days they didn't have total parental nutrition, and he became malnourished, and he died. And he died because he became immunosuppressed. So understand something. Total parental nutrition is one of the God saves. I'm telling you. I remember when it came out. I remember when it came out. So, total parental nutrition is probably one of the best inventions we ever did. Alright, good questions. Good questions, guys. Alright, let's take a little break. I'll see you shortly. All right. Okie dokie. Now, you can hear me, right? Right? Yes, yes, yes. I want to go to my email because some of you sent me. Wait a minute, I gotta look. Hang on, okay? I'm going to my. Let me go to my email. Okay, wait a minute, wait a minute, wait a minute. Okay. Wait a minute, I gotta do the. I'm not the fastest computer person in the world. Alright, now, can you hear me? Can you, wait, I gotta go back to this. Guys, can you hear me while I was doing that? Yes, okay, well, wait a minute. This is very important. Okay, I'm gonna go to my email, wait a minute. So you can hear me when I went, okay, wait. Alright, okay, there is, Namrita, wait a minute. Namrita, okay, wait, I want to see. Oh my, are you pretty? Okay. Alright, and this is you now. Okay, and a headshot. Okay. Oh my. My. Alright, now, let me do the next one. Okay. This is Samira, okay? Okay. Oh, great, you're adorable. Oh, that's a great picture. Okay. Alright, let me see if I can do this one. Okay. Oh, that's great. Oh, is that nice? Very, very nice. Guys, I have so many of them. I can't, I'm gonna go back to, I promise you, I'm going to go through all of these because I love them. Because now I can kind of put the name with the face. I really like that. Thank you very much. You guys are super for doing that. Alright, thank you for doing that. I mean it. I told you, the one thing I dislike about the online is I can't see you. I don't know why they can't have you, why they can't make it where I can see you as you're writing. I mean it. There's got to be some way to do that. Alright. Okay, thank you very much. You guys are the best. I mean it. Okay, number 11. A little baby is vomiting. A little baby is vomiting and has multiple dilated loops of bowel, but then has in their belly a ground glass appearance on the x-ray. Does everyone understand what ground glass appearance means? Tell me. Tell me if you don't. I'll explain it. Okay, let me explain. Guys, do you ever go to the airport and you see these snow globes? Like you take it and you turn it upside down and then there's like snow that comes down. Do you understand what those thingies are? Those snow globes? Okay. That is what ground glass looks like. It looks. Yeah, Alicia, you said gritty, little bits of glass. Yeah, they say Merry Christmas, things like that. That's what ground glass looks like, kind of hazy. In your brain, that's what it looks like. Ground glass. It's like those snow globes. That's exactly what it looks like. Whenever you see ground glass, and they will use that term, ground glass, and on your test they will specifically say ground glass. That is always meconium ileus. Always meconium ileus. Now, by definition, guys, the mother has cystic fibrosis. By definition, the mother has cystic fibrosis. And what does the kid have? Test question. Cystic fibrosis. Okay? Both the mom and the kid have cystic fibrosis. But you make the X-ray appearance of ground glass. They will always say that. Ground glass. Alright? So, what do you do in these patients? What do you do to make a diagnosis and also therapeutic? A gastrographin enema. Now, do you know why it's not only diagnostic? Very good, Nada, you caught yourself. Why is it also therapeutic? Don't answer this. Don't answer it yet. Tell me, when someone gets a CAT scan and they get gastrographin, what do they complain about after their CAT scan? Diarrhea. Oh my God. The best laxative in the world is gastrographin. The reason we don't give it generally is because you can really dehydrate someone from gastrographin. But in this situation, it is not only diagnostic, but it is therapeutic. So let's repeat that. That is such an important thing. Okay? A kid is born with multiple loops of bowel on the X-ray and a ground glass appearance. And you know how they describe what the belly feels like, guys? They call it doughy. Have you ever heard that expression, doughy, like dough, like a bread dough? Have you ever heard that? You know how bread dough is kind of doughy? You know what I mean? That's what their belly feels like. And that doughiness is actually the meconium. So you'll get an X-ray, and they'll say a doughy appearance. By the way, write this down. They will say on your test, a doughy feeling, yeah, mushy, soft and mushy. Very good, Zia. You know, doughy. It's a doughy feeling. And you get an X-ray, it shows ground glass. The mom has cystic fibrosis. The kid has cystic fibrosis. And you get a gastrographin enema, which not only makes the diagnosis, but it cleans them out. Alright? That's called meconium ileus. And guys, that's not terribly uncommon. They might not tell you that the mom has cystic fibrosis or the kid has cystic fibrosis. They may make you figure that out on your own. Doughy means, Justin, doughy means, you know what bread dough is? You know what bread dough, and you push on it and it's like kind of mushy. Do you know what I mean? That is what the belly feels like. Guys, when you feel your belly, it doesn't feel mushy. You know, it feels soft. You could push it in. When the bowels feel doughy, when you feel it through the belly wall. And remember, kids are real thin. And you feel it, and it feels like bread dough. And we call it doughy. We actually call it doughy. They're going to say it in the test. I guarantee it. They're going to say their belly feels doughy. Or the nurse is going to call you up and say their belly feels doughy. And it's like bread dough. I've never made bread, but I know what it is, okay? All right. No, it's not like edema, guys. It's like dough. I mean, meconium is thick and ugly. I don't know how to describe. It's like help me, guys. How would you describe meconium? Well, it's not like it's sticky, Arlene. It's like tarry. That's right. It's doughy. It's it's like Play-Doh. Guys, do you know what Play-Doh is? Do you guys know what Play-Doh is? Yeah, Play-Doh. That's a great example. It is like Play-Doh. Do they make Play-Doh anymore, by the way? They still make Play-Doh? Yeah, I remember Play-Doh. Can't you take pictures with can't you put Play-Doh on a cartoon and it picks up the, I don't know. I remember as a kid I liked Play-Doh. I used to eat it. I mean, I'm sure kids try to eat it too. Silly Putty, that's the other thing. Okay, that was it, Silly Putty. Do they still make Silly Putty? I don't know. Interesting. It's not pitting Eeyore, it's not pitting edema. It feels doughy. I don't know how else to say it. It feels like Play-Doh. It doesn't bounce right back. It like stays squished. All right? All right. Oh, wait a minute. We will, Diva, I'll get to that. Your question is always relevant, Diva. We'll get to that question. I used to eat the Play-Doh too. Diva, we'll get to that. Okay. Number 13. All right? You got a kid who's about 3 or 4 weeks old, and the parents bring in the kid, and they say, "You won't believe it. My kid vomited across the room. Across the room. And there's no bile in it." What is the diagnosis? Pyloric stenosis. Common? Yes. And test question, will there be bile in the emesis? No. And is it usually a boy or girl? A male, okay? And when we say projectile, guys, have you ever seen projectile vomiting? Have you ever seen? We're not talking about vomiting like you vomit. Yeah, that's right. Like The Exorcist. That's exactly right. That is exactly right. Okay? It's like The Exorcist. It shoots out far. All right? But I don't remember. Most people, Devin, in that movie, when that came out, let me just talk for a second about that movie. When that came out, people shut their eyes when things like that happened. That was one of the scariest movies. Did anyone, you're too young, did you see it when it first came out? Guys, when it first came out, people were taken to emergency rooms because they were so shook up. I mean it. It was really, really scary. Can I tell you one quick story? Do you know where it was filmed? It was filmed in Georgetown, in Washington, D.C. It was filmed in Georgetown. And at the time it came out, I finished medical school 6 months early. And I went to the NIH. Do you know what the NIH stands for? National Institutes of Health? You guys know what that is? It's in Bethesda, Maryland. All right. So I wanted to see where it was filmed. And so I went to Georgetown, and the house that it was filmed at with those stairs going up, I swear to God, I didn't want to go near that house. I mean it. That movie, when it came out, I know no one gets scared anymore in this day and age, but when that movie came out, that petrified. People were had psychiatric problems due to the fear. It was so well done. You know, next time you're doing nothing, oh, no, Devin, Alien doesn't compare to... Exorcist was truly one of the most frightening movies I've ever seen. And who said it? Yeah, you don't want to watch it alone. I mean it. Arlene, you're correct. You're in a house by itself, and it's very, very frightening. Okay, getting back to the kid with pyloric stenosis. They projectile vomit. It's not like vomiting, they projectile vomit. How do... Devin, you're not going to you're going to projectile vomit after dinner? After the lecture? Come on now. Devin, don't do that. All right. How do you make the... Oh, you're going to watch The Exorcist. All right. Don't be scared. All right, guys. How... Oh, and by the way, there's a big difference between watching The Exorcist on television versus watching it in the movie theater. I assure you, I'm telling you. That scared the you-know-what out of me. It did. How do you make the diagnosis of pyloric stenosis? One of the ways, Nava, you're correct, is ultrasound of the pylorus. Another way, you can get an upper GI. Another way, you can palpate the olive. They call it the olive. Okay? Any other ways? I'm purposely waiting because I want someone to say endoscopy. You do not do endoscopy in a kid. Why? Because you have to put the kid asleep. So this is the test question, guys. I wanted someone to say endoscopy. Listen to me. Thank you, Devin. No, Devin, it's contraindicated. Guys, they will say which of the following is not appropriate. They'll say ultrasound, which is fine. They'll say plain film of the abdomen, which is fine. They'll say palpation of the olive, which is fine. They'll say upper GI, which is fine. And then they'll have endoscopy, contraindicated because you got to put a kid to sleep. Now, let me explain something to you. The most common treatment, Justin, first of all, you usually know the diagnosis. I mean, an upper GI is when you drink barium and you take a picture. That's what an upper GI is, okay? The most common, Justin, is by far an ultrasound. By far. But I want you guys to know something, okay? The kid comes in and you kind of know the diagnosis. You know what I mean? There are not many things that can be other than pyloric stenosis. Okay? So most people get an ultrasound to make the diagnosis. Now, I do want to tell you something. And I want you to know this because this frustrated me terribly. Alright? Oh, they'll vomit up the barium, Arlene, but are their reflexes fine? Sure. They won't aspirate. Will you aspirate? No. You won't aspirate. They're fine. They will vomit it up. Now, they don't give them a whole hell of a lot of barium. You know, they don't want to, hey, let's see how much this kid can throw up. You know, but they just want a picture. Now, listen to me carefully, guys. When I was your age, I kept wanting to feel the olive, meaning palpate the thing in the belly. Can I explain something to you? Don't tell this to the professor, okay? You'll never feel the olive. What do I mean? The kid will never allow you to feel that deeply until the kid's asleep. When I was your age, every kid with pyloric stenosis, I tried to feel the olive, and the kid would be screaming. And I'd say to myself, well, why can't I feel the olive? Guys, you'll never feel the olive until the kid's asleep, because they won't let you push down on their belly. Now, your professor will say to you, did you feel that olive? And what you learn to say is, yes, but you really didn't. Do you understand that? And the professor didn't feel it. They're just saying it, okay? You can't feel it until the kid's asleep. I want you to understand that. The kid won't let you go deep in their belly. Okay, let me tell you one more story about a mistake I made in pyloric stenosis. All right? As you kind of can tell, the one word that people use to describe me is intense. I am. I'm an intense person. I know that. All right? I'm not funny. I'm not funny. I'm not a funny guy. And I always admired people who were funny. I mean, who could who are like funny, light. I'm not light. I'm intense. It's the way I am as a person. Okay. There are physicians, guys, And you know physicians who really can sometimes give humor, a little bit of humor, and lighten the situations. Do you know what I mean? Thank you, Arlene. You're sweet. But I'm generally intense. But do you know what I'm saying? Like that there are doctors who can lighten up a situation by kind of being funny in a way. Do you know what I'm saying? You know what I'm saying? There are people who have... Okay. There was a family who came to me with a pyloric stenosis. Not sarcastic, just light. They're just light. They're able to make nice, simple jokes that make people comfortable. Witty. Yeah, stuff like that. Okay. There was one of my first pyloric stenosis. The family was so nervous, and they came to me, and I felt so badly that they were so nervous. And they said to me, they said, Dr. Hill, have you ever done this operation before? And so I thought, you know what, Mark? I'm going to try to be light like that. And I said to him, I said, no, this is the first time. And they just sat there and looked at me. I said, please excuse me. I apologize. I've done many, many of these. And I was just hoping to relieve your anxiety. Guys, I never, ever did that again. I don't have that flair for the humor and stuff like that. So guys, I just thought I'd tell you that story because I never forgot it. I never forgot them. No, yes, it came off as sarcasm. Oh, but I was so embarrassed. I've never done that ever again. There are some doctors, guys, who can be light. Do you know what I mean? They're light. They're just, yeah, I saw them again. They trusted me. And there are some surgeons and doctors who can joke, and it doesn't come across as being a smartass. It did with me, and I've never done it before. I've never done it since. So when you make the diagnosis of pyloric stenosis, do you know what operation you do? Oh, wait a minute. I want to answer this. Justin, the most important thing, Justin asked a great question. Guys, first of all, you don't do an operation if you haven't done it before. You just don't. Wait a minute, guys. I want to answer Justin's question. You don't. You got to have experience. But if someone says, have you done 1,000 of them, you know, something like that, guys, a patient has to have confidence in you. And usually what I'll say is, I've done plenty. And not to worry. You don't get into numbers. Because if they ask you how many and they don't like it, they'll go to someone else. All right? The operation you do, Justin, that was a great question. You do a pyloromyotomy, which is a sphincter splitting, and no one says that word, sphincter splitting. It's a pyloromyotomy. Look, this is the pylorus. You cut the pyloric muscle. You do not go in the lumen. And what happens is, goes like that. And it doesn't come back. Now, if you're the only surgeon on an island, obviously you got to do it, okay? I don't like sphincterotomy. No, Arlene, it's a pyloromyotomy. Because think about the word. Pyloro means pylorus. Myotomy means muscle. You do not go into the lumen. You just go like this. And it's very easy and very quick. So it's called a pyloromyotomy. Don't say sphincterotomy. Don't say sphincter splitting. Say pyloromyotomy. It's a very quick operation. It really takes just a few seconds. You cut it and you're done. All right, and it doesn't come back. So and tell me, test question, what will they be, hyperkalemic or hypokalemic? Will they be acidotic or alkalotic? Oh, alkalotic. Oh yeah, guys, these kids have big electrolyte abnormalities. So, has anyone ever seen a pyloric stenosis? Has anyone personally, have you guys, any of you as children, ever had pyloric stenosis? No? Usually someone has it as a child. Alright. Let's go to number 14. Alright? Number 14. This is a 8-year-old baby and has jaundice getting higher and higher and higher. And guys, this is classic for biliary atresia. And this is a terrible disease, because what biliary atresia means is that the biliary tree is not developed. And what do these kids need? Well, they need what? A transplant. They need a liver transplant. And what you do is you send them to a tertiary care center. Has anyone ever seen a biliary atresia? It's awful. It's awful because they need a transplant. And you're correct, Arlene. A lot of them died because they can't get a transplant in time. And if you're, it's like having obstructive jaundice, and they die. Yes, Diamond. Arlene has seen everything. Arlene, where are you again, Arlene? Where are you physically? In Grenada. You have seen a lot. You have seen a lot. All right, but you worked in Jamaica. Okay, fair enough. All right, so that's biliary atresia. And you're Jamaican. All right, well then you've seen an awful lot, I'm sure. So guys, biliary atresia is a bad, bad, bad entity, and they need a transplant. And the problem is, even if you get them to a tertiary care center, how quickly could you get a transplant? I mean, you're asking for a pediatric transplant. It's very, very bad. You need a donor. It's just awful. It really is awful. All right. Let's continue. Number 15. A kid comes in because of chronic constipation. And the kid has abdominal distension and has dilated loops, and something's not right. This kid, by definition, most likely has Hirschsprung's disease. Hirschsprung's disease. What is the other name of Hirschsprung's disease? Because this is a real important thing. Aganglionic. It's not megacolon. Zia, you cannot call it megacolon. That is not correct. It says in your book megacolon. If you say that word megacolon, you will confuse people with toxic megacolon. Please don't use that word. Say colonic aganglionosis. Megacolon, as soon as you say that word, I know it's written in the book. I want you to scratch it out. People think of toxic megacolon. Okay? Don't use the word. Someone is going to get the wrong... call it colonic aganglionosis. So now I'm going to ask you a question. Is this an anatomic or functional obstruction? It is a functional obstruction due to the lack of no, not my enteric plexus. The lack of what? The lack of ganglia. The lack of ganglia. Okay? So, this is a child who has colonic aganglionosis. It's a functional obstruction. Can you tell me what other disease in the esophagus is a functional obstruction. Achalasia. And remember what I told you. An aperistaltic segment of the intestine is a functional obstruction. That's so important, I'm going to say it again. An aperistaltic segment of the intestine acts as a functional obstruction. So let me ask you a question. Think. Most of the time, Hirschsprung's is in the distal large bowel. If you get a barium enema on these kids, the proximal bowel will be dilated. Is that proximal dilated bowel normal or abnormal? It's normal. It's just dilated. It's normal. The narrow segment, Diva, you don't have to apologize. The narrow segment is the Hirschsprung's. That's so important, I'm going to say it again. Hirschsprung's usually occurs in the distal portion of the large bowel. If you get a barium enema, that portion of the Hirschsprung's will be narrow, but the proximal bowel to that will be distended. That distension is normal. It's normal bowel, but it's distended because you have a functional obstruction. A functional obstruction. All right. So you're thinking Hirschsprung's, functional obstruction, you get a barium enema. Tell me how you make the definitive diagnosis of Hirschsprung's. You do a biopsy of what? Of what? The rectum. The rectum. Because if you did a full thickness biopsy in the abdomen, you'd get a perforation. So you do it of the rectum. Guys, that's a test question. The rectum. And this is a hard question. What are you looking for? The lack of, very good, Zia, the lack of ganglia. The lack of ganglia. So let's say that again. This is so important. Very good, Devin. It's so important. You think about Hirschsprung's. The kid presents as Hirschsprung's. You get a barium enema that looks like Hirschsprung's. The definitive diagnosis is made by rectal biopsy, and you look for the absence of ganglia. Okay, so now you got a kid with Hirschsprung's. What you gonna do? What you gonna do? Alright, Aminata, you would resect the colon, the bad colon, and do a pull-through, pull the good bowel and sew it to the anus. It's called a pull-through operation. And 2 days later, first you would wipe up all the poopy away, and 2 days after you did that operation, the anastomosis would go like this, boop, fall apart, and you would be sued. Is this kid healthy or sick? Many times, Diamond. Is this kid healthy or sick? Sick. So therefore, what must you do? You want to do two things. You want to, first of all, relieve their obstruction, and you want them to be able to eat. You do a colostomy. Does everyone understand why This kid is not a healthy kid. This kid has not been having regular bowel movements, and when you don't have regular bowel movements, does that make you hungry or not hungry? It makes you not eat. Guys, when you have a Hirschsprung's, the first thing you do is a colostomy, and that allows them to defecate through the colostomy, and it allows them to eat. Then, when they are reasonably healthy, you don't have to wait a year, several months, then you do that operation called a pull-through, where you take out the Hirschsprung segment and you pull through the normal bowel and sew it to the anus. Test question. What is the #1 complication of a pull-through procedure for for Hirschsprung's? This is a hard question. Not anal stenosis, good answer. Not ruptured, Evan, good answer. Not perforation. Very good, Nada. Incontinence. Incontinence. Guys, your anus is very, very, very smart. I'm not joking you. Your anus is very smart. What do I mean by that? Your anus can differentiate very well between gas, solid stool, and diarrhea. Now think about it. How many times have you ever had an accident? Not many. Your anus can differentiate very, very well between those three things. Gas, liquid stool, and solid stool. When you start mucking around with the anal sphincter by doing a pull-through operation, some of these patients will have trouble with incontinence. And that's a big problem. So this is a little bit above you, but I just want you to know that they can have trouble with incontinence. Let me ask you a medical question. How can you tell if you're with friends who have trouble with incontinence? How do you know that they have trouble with incontinence? No, they don't smell, Laura. No, come on, seriously. I'm serious. Well, Alicia, your answer is clear, but there's something even more. Guys, let me explain. When someone is incontinent, they're not incontinent in the sense that they just defecate. You can hold it. You can hold your poopy, for hours. When someone is incontinent, they can't hold it for a long time. So the way you always know if you have friends who have trouble with this is when you go out to eat or you go to a movie or you go to a show, they always know what? They always know where the bathrooms are. Seriously, guys. Guys, I've had a lot of patients with Crohn's disease, and I've had friends with Crohn's disease. And when they go to a place like, movie or something like that, one of the first things they do is they know where all the bathrooms are. One of my good friends was a policeman who had terrible Crohn's disease. And it used to get so bad, he would tell me that when he was chasing a criminal, he would have to go into the bushes to defecate. He had to retire. He had to retire from police work because of that incontinence. So guys, when we talk about incontinence, it's usually not where someone just defecates. It's that they can't hold it. And so they have to get to a bathroom immediately. Just like people with Crohn's disease, just like people with ulcerative colitis, things like that. They can't hold it like you and I can. So I want you to understand when we talk about incontinence, it's usually not gross incontinence. It's that, and oh, now, excellent, Eroy, that's, oh, did you say the right thing? There are people, read what she said, okay? There are people who will choose to have a colostomy rather than to be incontinent because they can function normally. That's a very, very good point. And guys, remember, what operation did we do for synchronous tumors of the colon? A tolectomy. And someone asked, do we sew the ileum to the rectum? And I told you that they get diarrhea. There are some people who will decide, Dr. Hill, don't sew my ileum to the rectum, give me an ostomy. Because their quality of life, they can do everything with an ostomy. You know, that's an excellent, excellent, excellent point. That some patients will say to you, there's no way in the world I want to be even slightly incontinent. Oh, no, Justin, it's not rare. No, Justin, no, 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 no. It isn't rare at all. When you start mucking around with the anal sphincter, I'm very serious about this. When we do hemorrhoidectomies and we do fissures and sphincterotomies, oh, one of the things we worry about is making someone incontinent. And it's a real, real problem. And so you got to be careful. That's why when you do a hemorrhoidectomy, you got to be careful of that sphincter. You do not want to remember which is the sphincter that holds it in, the external sphincter. You got to be very, very careful. And when you do this is very advanced for you, but I'm just going to tell you, when you do a fistulectomy, remember I told you a fistulotomy, I mean, when you have a fistula in ano, which comes from a perirectal abscess, and you have to do a fistulotomy, oh, guys, you got to be very, very careful that you don't all of a sudden make that patient incontinent. Seriously, this is really important stuff. You don't want to ever make someone incontinent. Okay, so let's get back to Hirschsprung's again. In Hirschsprung's disease, again, let me explain. This is so important. In Hirschsprung's disease, it's a functional obstruction due to colonic aganglionosis. Guys, don't use the word megacolon. Just don't. It's not a good word in this situation. You make the definitive diagnosis by doing a biopsy of the rectum looking for the absence of ganglia. Okay? And the initial operation you do is you do a colostomy. So the patient can defecate, they can eat, you clean them out a couple months later for an operation, and then the second operation is the pull-through. You take out the Hirschsprung segment, throw it out, and you bring the normal bowel down to the anorectum, and you sew it up. And hopefully they won't be incontinent. Hopefully they won't be incontinent. Has anyone ever seen a Hirschsprung's? Yeah, guys, this is not uncommon. This is not uncommon. But please erase from your brain the word megacolon. It's a terrible word to use. If you don't want to use Hirschsprung, say colonic aganglionosis. Now, I will tell you one final thing about this. No, 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 it's not a Hartmann. Guys, Emanado, let me just tell you what that is. I want everyone to understand what a Hartmann is, okay? Listen to me carefully. Guys, listen. Write this down. When you have diverticulitis and you have to take out that portion of the sigmoid that's diverticulitis, and you take out that portion and you do an end colostomy and sew up the distal rectum, that is called a Hartmann. Let me repeat it. Guys, that's a Hartmann. Let me repeat it. In diverticulitis or cancer of the sigmoid, when you take out that segment and you bring up a colostomy and sew up the distal segment, that is called a Hartmann. Does everyone understand? That's a Hartmann. A pull-through is you really pull it through. You're taking the bowel and you're pulling it down and you sew it up. Totally different. Totally different. All right? Everyone with me on that? A pull-through operation. That's what a Hirschsprung's is. And remember, one of the things I want to just tell you something that I always wondered. There is no anatomical obstruction in Hirschsprung's. And I always wondered, why couldn't the proximal bowel, by contracting, why couldn't it shoot through the Hirschsprung segment? It never made sense to me. I always thought about the Hirschsprung segment as like a toilet paper, no, a toilet paper roll, meaning the tube, the cardboard tube. Why couldn't the colon just shove it through? It doesn't. It's a functional obstruction. A functional obstruction. Does everyone understand it's not an anatomic obstruction? The reason I say it to you is patients will say, where's the blockage? And you say, well, it's not really a blockage, and they'll never understand this. You say that there's no nerves there, and they'll say, well, why would that make a blockage? You will never get anywhere with the patient explaining this, so you don't get into it too far, because they won't understand it. All right? The tone in the Hirschsprung segment is, it's not that it's high, Arlene. It's that there's no tone. It's like a floppy nothing. Believe it or not, you need peristalsis to move things along. And if you don't have peristalsis, nothing will go through. It's really that significant. It's a well said, Dinesh. It's a lifeless. It's floppy. It's like what's it called? It's like it's got no substance to it. You understand? It's not that the tone is tight. It's nothing. It's like it won't. You can't get anything through it. It's like I'm trying to think of. I don't know. I can't think of something that's analogous, but it's just. It's got no peristalsis, no tone, no nothing. All right? Does everyone understand what Hirschsprung's is? Colonic aganglionosis. Don't use the word megacolon. Bad, bad word. People will think toxic megacolon, ulcerative colitis. Please. Yeah, like squeezing a tube of toothpaste. Yeah, similar to that. What do we resect in the Hirschsprungs? We take out the Hirschsprungs. Did we take out that portion of Hirschsprungs? You're not going to leave it in, and you take it out. And you connect the good bowel to the anal rectum. And you take out that narrowed segment. Everyone understand that? All right. And that's really very, very straightforward. Hirschsprung's disease. Remember, just like in tracheoesophageal fistula with esophageal atresia, where their first operation is a gastrostomy, in Hirschsprung's, your first operation is a colostomy. Clean them out. Get them healthy. And then do a pull-through. Okay? All right. Let's take a little break, and we'll be back shortly. Alrighty. Okay. All right. Very, very good. Let me just do this for a second. All right. You guys asked some very, very good questions. Very, very good. I'm very, very pleased about the questions you asked. Does everyone understand the difference between a Hartman procedure and a pull-through? I want to make sure that you know it, because they use the word Hartman an awful lot. In other words, they use that a lot. Does everyone understand it? All right, a Hartman means you take out the sigmoid, you bring up a colostomy, and you sew up the distal end. And they call it a Hartman procedure. That's what a Hartman procedure is. Okay? All right. Now, let's continue on and get to the next case, which is always one of my most interesting cases I like to talk about. And this is number 16. Okay? Say what again? Should see the Hartman? A Hartman is when you take out the sigmoid colon, you bring up a colostomy, and you sew close the distal rectum. That's called a Hartman procedure. Hartman. Okay. All right. Number 16. Parents come in with a kid, and the kid has been colicky and just not feeling right. And the parents come in and they say, the poopy looks like currant jelly stool. Currant jelly stool. What is the intussusception? What is intussusception? Very good, Arlene. Telescoping a bowel. Telescoping a bowel. Is that good or bad? Bad. Why? The piece of bowel that is... No, it doesn't happen in old people, Justin. The piece of bowel that is inside is telescoped. What's going to happen to that segment? The blood supply will be compromised. Yes, ischemia, okay, you're all saying the right thing. So now, let's talk about something. We have to talk about currant jelly. You see, because when I learned about currant jelly, I thought currant jelly, being a city boy, meant the jelly of the day. I'm very serious about this, guys. What is currant jelly? What does it look like? What does it look like? It's very important. Kind of a reddish purplish color. It's thick. It's thick, and what does it have in it? It has seeds in it. Alright, it has seeds in it. Okay, so that's what currant jelly is. It's not like the jelly of the day, but it's a good jelly. Now, listen carefully. What is the red of the currant jelly? Blood. What is the thickness of the currant jelly? Mucus. Very good. From ischemia. What are the seeds of the currant jelly? No. No. The seeds are, very good, Nada, you get the gold star. And Nada, you get it, the epithelium. So let me repeat this. Clap, 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 clap. Listen. The redness of the currant jelly is blood. The thickness of the currant jelly is mucus from ischemia. The seeds of the currant jelly is sloughed epithelium. And guys, have you ever seen a currant jelly stool? It looks exactly like currant jelly. I mean, you wouldn't want to put it on a cracker and eat it, but if you saw it, it does not look like poopy. It does not look like poopy. It looks like currant jelly. And now you understand the blood, the mucus, the epithelium, why it looks that way. Okay, so now, what is the most common location of intussusception? It is the ileocecal area, okay? Now, guys, why do we think people get intussusception? Meaning, if kids had a polyp in their bowel, you can kind of figure out that it would pull in telescope. But kids don't have polyps. Kids don't have polyps. A Meckel's, Justin, is on the outside. Is on the outside of the bowel. So now I'm going to tell you a very, very important story. Someone, who was the one who talked about, Jose, was it Jose? Who we talked about why you don't operate on your own kids and things like that? Jose, was that you? Okay, listen carefully. This is related to what I'm going to talk about. I'm very serious, it's a true story. When my son, Adam, was about a year old, he had a bad sore throat. And I decided, well, I'm going to look in his throat myself. Guys, one of the things you got to realize is that when you're dealing with your own family, even though you're a doctor, your brain will disengage. Meaning, I looked in my son's throat and I thought, oh my God, he's got 2 big tumors in the back of his throat. What were those 2 big tumors? Tonsils. And we all know that at a young age, kids have big lymphatics. So my first point is getting back to Jose's point. Guys, you cannot think clearly, generally speaking, on your own family because your brain disengages. If you care anything about your family, you can't think objectively. Okay, now let's get to the point about kids. He was 1 year old. His tonsils are this big. He didn't have tonsillitis. He just had big tonsils. Okay? Is there any part of the bowel that has a lot of lymphatic tissue? Very good, Diva. Peyer's patches, Aminata, correct. The ileum. Guys, there are Peyer's patches in the ileum. And it is thought that the reason why you get intussusception in the ileocecal area is because of Peyer's patches. That's what it's thought. Is it proven? No. How can you prove it? But it's generally thought that this is the reason, because in this age, a year-old kid, that their lymphatics are large and Peyer's patches will pull it through. That's thought to be why. Now, how do you physically make the diagnosis of intussusception? Now, you're thinking about it, but how do you physically make it? I said physically. Yeah, here's what they say. An empty look. I said physically, guys. Physically. Clinically. Alright? That's okay, Arlene. Guys, they say you feel an empty right lower quadrant and a sausage in the right upper quadrant. Now let me tell you something. You will never feel that. Your professor will say, I will say, oh, it's an empty right lower quadrant and a sausage in the right upper quadrant. You'll never feel that unless the kid's asleep. I'm just telling you, you won't. The kid won't let you do it. And if you ever do feel it, you're lucky. But most of the time, no. So, I just want you to understand, just like pyloric stenosis, you're not going to feel it, even though the professor, like me, will say, feel the olive? Yeah, like hell you're going to feel the olive, okay? You're just not going to do it. The kid won't let you go that deep. Okay. So, you think about the diagnosis of intussusception, and how do you definitively make the diagnosis of intussusception? You do a barium enema. A barium enema. And not only is a barium enema diagnostic, a barium enema is also therapeutic. Therapeutic. Meaning you give the barium enema and it goes, pulls apart. Listen to me carefully. Test question, if there ever was a test question. In order for you to go home, you must see reflux of barium in the terminal ileum. That's so important. I'm going to say it again. In order for you to go home, you must see reflux of barium in the terminal ileum. That's so important. I'm going to say it a third time. In order for you to go home, you must see reflux of barium in the terminal ileum. Why is the home, meaning the kid goes home? In other words, the kid's fine. Guys, why? If you have a little itty bitty bit of intussusception still there, can you just forget about it? No. What'll happen to that little itty bitty bit of intussusception? What's the kid gonna, what'll happen? No. That piece that's still intussuscepted, what's gonna happen to it? It's gonna necrose and you're gonna perforate. You must have reflux of barium in the terminal ileum to go home. You will not have a complete reduction unless you see reflux of barium in the terminal ileum. Guys, I cannot stress this enough. If there's ever a test question, this is the test question. Do you understand that? Okay, so now let's say that the radiologist says, Mark, I can't do it. I can't safely reduce it completely. Okay? And you are correct, Arlene. Listen to what Arlene said. Is there a risk in doing a barium enema? Meaning, do you put it on a big pressure bag? No, you can blow out that weakened segment. So you have to be gentle. A radiologist will not be tough. If they hear him, they will say, They will say, So do you understand what I'm saying again? Let me repeat this. It's so important. You might think that in order to get rid of the intussusception, connect the barium to a pressure bag, like a hose, and really pressure it in to pull out that barium enema, to pull out that colon. Guys, if you have an ischemic area, yeah, you'll pull it out and you'll perforate it. So a radiologist will actually have a limit to how much pressure they will give of the barium to do this procedure. So therefore, if the radiologist cannot reduce this by barium enema, then you have to take the kid to surgery. Does everyone understand that? A radiologist will never, ever, ever take a chance. Because if they're reducing it and all of a sudden they perforate, changes everything dramatically. Does everyone understand that? That you cannot put a pressure bag on this. You can't squeeze it as hard as you want, like a balloon. You'll blow out that colon. You got to be gentle. Are you with me so far? Because you got to listen to what I'm going to say now. You with me? All right. If they cannot reduce it, then you have to go to surgery. Now, when you go to surgery, when you operate on a kid with intussusception, you mobilize the tissues. Do you know what mobilize means? When we use the word mobilize, do you know what that means? Free up. Arlene, that's correct. We kind of we bring up the bowel to the surface of the belly. Listen to me carefully and picture it in your mind's eye. The process of mobilizing the bowel, you reduce it. It's much easier to reduce it by your hands like this than blowing into it like the barium enema. You understand? You understand this concept? Okay, so it's nothing. It's nothing. You go like this and then beep, and that's it. It's much easier to pull. It's like my sleeve. Wait, where's my sleeve? Wait, see my sleeve? It's easier to pull it apart than it is to blow it from the inside. Everyone understand this? Okay, now let me tell you one of the biggest mistakes I've done. Alright? I am technically a fast surgeon. I've always been a fast surgeon, and I pride myself in getting patients in, on and off the table fast. Alright? My first intussusception. The first intussusception, the barium enema didn't work. Go to surgery. Kids are skinny, right? They're little kids. You make your incision, in a minute you're in the belly. I go like this, whoop, mobilize my ileocecal area, pulls apart, put the bowels back, close up the kid, thin kid, and I'm out of that operating room, swear to God, skin to skin, in, 10, 12 minutes. Now, when you watch television, do you ever notice that they always watch the clock? On television, they always have pictures of the clock. Always. And you always see the surgeons sweating. You know, they have the hats on, and you see the sweat. Listen to me carefully. These are things that just us doctors have to know about what I'm going to tell you. The public has a conception of how long an operation should take. They have a conception of basically how long an operation should take. And when I came out in 12, 13 minutes, and I said everything is fine, they looked at me like I had three eyes. And they looked at me like either one of two things. You didn't do anything, or my kid didn't need an operation. Let me explain this very important point. If you took your car in to get new brakes, and 5 minutes later they came out and said, "Hey, we're all done," what would you think? You wouldn't believe it. But yet you know at the Indianapolis 500 that there are people, they have these crews of people who physically can do all that stuff in 30 seconds, okay? But you believe that it takes, a certain amount of time to do something, okay? And guys, this is not something you tell non-medical people. But I learned from that, and Justin, you're right. When I do an intussusception, and I open up the patient, and I reduce it, I will have everyone examine that patient. I'll say to the medical students, go explore that patient's belly. Go ahead. I'll call in the janitor from outside. I say, come on in and explore the abdomen, okay? Guys, I will drag out that procedure to at least 30 minutes. Because I've learned in 33 years of practice that when I come out from surgery and the family says to me, "Boy, Dr. Hill, that was fast," that may not be a compliment. Do you understand what I'm saying? Do you understand what I'm saying? When they say to you, "Boy, that was fast," that may not be a compliment to you. Just like when you go in the dental chair, and if you were done in 5 minutes, you kind of, did you do everything you were supposed to do? Guys, this is not something you talk to non-doctors about. This is something that we recognize that the public has a conception about. So, what happens is I usually, on something like that, I usually take like 30 minutes. And Justin, you said the right thing. I'll write my note first. I'll go over things. I'm telling you, you don't want to come out too soon, because people will look at you like either you didn't do anything or the person didn't need an operation. Always remember that. This is not something that you'll ever see written in a book. You'll never discuss it to people outside the medical profession, but every seasoned surgeon and physician know it. All right? Do you understand? All right. So now, one of the questions is, why don't we get intussusceptions again? Why doesn't the kid get it again? Meaning he's still got the Peyer's patches. It's thought that the reason that they don't get intussusception again is that they get adhesions. They get a little bit of adhesions that keep it from telescoping. Shristi, can I say something about your sentence that you just said there? When people, I'm just going to tell you from just my experience, when people ask me, family asks me, how long it's going to take, I always say that the operation will take as long as it takes. That's how I answer it. I don't say it in a mean way. I'm not a smartass. But I say to them, the operation will take as long as it takes. Because you will drive them crazy. If you tell the operation them it's going to take 30 minutes and it's an hour, it's going to be 2 hours, and you come out in half an hour, they'll think you didn't do something. Guys, the worst thing in the world is to give them an exact time. I always say, yes, they'll watch the clock. I always tell them, I say, it'll take as long as it takes. And that's what I say. That's where my intensity always comes out. I'm not a light guy. I can't make good jokes. So I tell them, I say, it'll take as long as it takes. Wait here, please. And I promise you, I will come out, when I am done. And I've always done it that way, because people go nuts when you tell them a time and then it's longer than that period of time. Does everyone understand this point? It's a very important point. All right. Remember something. Patients may not, and family may not remember all of the medical things you say, but they will remember all the non-medical things you say. If you ever say anything bad, they'll remember it exactly. You come across as a jerk, they will remember it exactly. And don't ever forget this. I tell you these stories, again, not just to teach you intellectually, but to teach you to be good and great physicians. All right, and to do the right thing. And guys, I wasn't born this way. I learned it from my late partner, who was my mentor. Now, this is a good question. Arlene wrote, is paucity of words a better option? No. Because what do people interpret when you don't say a lot? What do they interpret that as? Right, something serious, something you're not telling them. Guys, one of the things you just have to learn the interpersonal relations. In other words, you always sit down. Always sit down. You never stand and talk to someone because they'll think that you're in a rush. It's like, have you ever seen people put their hand on the doorknob? Worst thing in the world you could do. Even if I'm going to be 30 seconds with a patient in my office, I'll sit down. I will sit down and I will look at them and I will put my hands like in this. I will give them the time. Don't be a jerk, guys. And you talk to them, and you talk to them regular. Don't talk to them like a doctor. They won't understand. Talk to them nicely. Be nice. Be caring. Do the golden rule. You know what the golden rule is? Treat them as the way you'd want to be treated. Okay? Don't ever forget that. Your question is a very, and Justin, you said a very good thing. Yeah, you do get sued less. There's no question that the number one reason why people get sued is because of poor communication. Without any question. Without any question. You will not have this immediately, guys. This is something you will learn by making mistakes. Like I did with that pyloric stenosis, and I said, this is my first one. I did do another mistake also. I remember years ago, I had a patient who had a scalp laceration, an old patient. And I sewed it up, and I was putting pressure on the wound. And again, I'm not a funny guy. I just don't say things funny. And the patient said, Dr. Hill, what are you doing? And I said, I'm holding in your brains. And the patient said, really? Guys, I felt like an idiot. I said, no, excuse me. I never said that again. In other words, it's just not, you have to be able to communicate with patients in a nice, gentle way. I love the fact that you're asking me these questions because it means you're going to be great doctors. The people who don't ask these questions will be idiots as doctors, and they won't have patients who are loyal to them. And this is very important that you ask these questions, and you have to get the answers, and you have to hang around professors who will teach you this. Medicine is a profession like no other profession. The patients look at you in a special way. It is a special calling, and they want you to talk to them on a regular, gentle level. And don't be afraid to be warm. I'm telling you, to be warm, to be nice, to be gentle. Don't be a jerk. Okay? Guys, I'll just say one more thing before we continue. Do you know why patients nowadays want women as doctors as opposed to men? Do you know why? One of the big reasons? You bet, Arlene. You bet, Justin. You bet. Generally speaking, you're correct. That women they're more nurturing. They're nicer. It's true. And so you have to try to men. You can't be a cowboy. You can't be macho. You can't be Arnold Schwarzenegger. You know, you got to be nice. Don't forget that, guys. They're just patients. You got to treat them nicely. Don't be a jerk. Okay. All right. So again, it's really important. I have seen so many jerks as doctors. All of you asking these questions, I now know that you will think about it. And let me just tell you one more thing before we continue. My late partner was a very tough guy. He didn't talk a lot. I'm a talkative guy. He didn't talk much. And when I started with him 33 years ago, do you know what he would do? Privately, after every day, he would take me aside and he would say, I didn't like the way you dealt with that situation. Meaning not medically. He'd say, you should say these words or this thing. And he didn't say it a mean way. He was just a tough guy, you know. And he would teach me how to communicate with patients so that they became close with me. And the one thing that I treasure more than anything else is my patients are very, very loyal to me. And if I told them to jump off a bridge, they would jump off a bridge. Seriously, they trust me. And you're right, having a good mentor, and I will tell you when I talk to you again on Sunday, how mentors changed my life. So guys, this is so important that you're asking me. Hang around people who will answer your questions and people who will mentor you. You cannot learn it from a book. Medicine is still an apprenticeship. And yes, Dinesh, it is very rare. I have close friends who don't give a crap about the residents and the students. And I tell them privately, I'll tell my friends, I'll say, why don't you spend 5 minutes and talk to these guys? And they say they could learn it on their own. And that's the attitude that is bad. And you wonder why I'm a dinosaur and stuff like that, because I feel that my obligation to you is not just to learn all this stuff. It's not to learn just all this stuff. It's to learn how to be a caring, trusting physician. I really mean it, guys. I cannot stress it enough. All right. Thank you. Thank you for, Justin, that's nice. That is nice. And you're correct. You know, I can tell you story after story after story. And don't be an idiot. Please excuse me, folks. Don't be an asshole. Please excuse me for saying that. But don't be it. All right? You never want someone to say that about you, that they can't stand. That you never want someone to say, oh, that doctor is a smart doctor, but I can't stand him. You never want that. You want the combination of that they like you and they think you're smart. I really mean it. Okay. All righty. Let's continue now. Any questions further on intussusception? Has anyone ever seen it, by the way? You had it. You actually had it as a child. That's very interesting. Very interesting. Very good. Very good. All right. Number 17, 18, and 19. This is very important, guys. 17. A kid comes in with subdural hematoma and retinal hemorrhages. Number 18. A kid has a fractured humerus and there's X-ray evidence of old fractures. Number 19, a kid has burns of both buttocks. What is the likely diagnosis? Child abuse. And that is correct. Now guys, let me tell you an important aspect of child abuse. Listen carefully. Guys, I don't know if you know this, but you need to know this here in the States. If you are examining a patient and then you go to the nursing station and the nurse is kind of listening to what you're mumbling about or something like that, and if you happen to mumble the words child abuse, and if that nurse then makes that phone call of child abuse, you can't reverse it. Do you understand what I am telling you? I cannot stress this enough to you. Once the nurse calls that in, you can't say, oh, I didn't mean it, I didn't mean it, I didn't mean it, because they do it for the protection of the child, and at least in Illinois, it's 48 hours. The child will be taken away from the parents for a minimum of 48 hours until it's proven. And if you make a mistake by mumbling it or saying it, they will hate you. Okay, let me tell you a story. About 5 years ago, there was a little kid who came in that got ravaged by their own pet. It was a pit bull. Okay? I mean, this kid, oh my God, I was hours and hours and hours in the operating room sewing up this little girl. I was furious. I came out and this was their pit bull, and I was all set to, in my heart, I was all set to personally call to get child abuse. And I met with Mom and Dad. They were the nicest people in the world. The dog was a nice dog. The child did not provoke the dog. The dog had no history of this. And the dog just attacked her. Guys, I was going to do child abuse. I mean, from my emotional. And all of a sudden I realized this isn't child abuse. I mean, they were not abusive. It was one of those terrible, terrible accidents. And thank God I kept my mouth shut. I didn't say anything to the nurses. Okay? And yeah, they killed the dog, absolutely, without any question. Absolutely, without question. But, you know, it wasn't child abuse. So my point to you, and this is a very important point, if you ever mumble it, or if you say, talking to your colleagues there, geez, I wonder if this is child abuse, and the nurse takes it upon themselves to call it in, it's irreversible. Does everyone understand that? I'm going to ask you a tough question. Have you ever had a situation like mine where you were all set to think this was child abuse and it wasn't? Alright, so some of you have had that situation. Did you recently see on the news that woman in Baltimore who grabbed her kid. Who, did you see what I'm talking about? She was a hero. No one said that she was doing child abuse. Oh, Natty, you didn't hear what happened? Her son, it was a great thing. Her son, during, the Baltimore riots, okay? That's correct, Emanata. It's not abuse, it's protection. The Baltimore riots, because of all that junk going on. Her son was going to throw rocks and go to the police and, do all this. And the mother was fantastic. She runs, and you could hear her screaming at her kid and said, "Get back here, get out, don't you get involved with that." And she was hitting him, not punching him, just, you know what I mean, slapping her around. And she's now been on television all over because she's like, this famous person now because she did the right thing. She wasn't being abusive. She was trying to protect him from getting into a situation where the kid might have actually gotten killed by the police for attacking the police. So the point is, my point to you is that you have to be very, very careful about child abuse. Don't say it unless you're sure about it, all right? Because I'm telling you, you make a mistake and the parents have to pay for it, all right? Finally, number 20. You already know the answer to this. A 7-year-old kid passes a large, bloody bowel movement. Do you work them up with a endoscopy and all that stuff? No. What do you think about? A Meckel scan. Very, very good. Very, very good. All right. Okay, now, ask me questions. Let me just tell you, we are way ahead of where we need to be. I'll be lecturing you on Sunday again, so I'm yours. Go ahead. Questions? Anything I talked about today, the past few days? Questions at all? Anything you don't understand? Questions? Any questions about anything? Oh, okay. Good question, Diva. If you use barium for meconium ileus, and if you used it in meconium ileus, what does barium turn into? What does barium turn into? It turns into concrete. You'd never use barium for meconium ileus, ever. Ever, ever, ever. Very good. All right. Okay. Do type 1 diabetics have any difficulty? No. No. You know when you get hypoglycemic, you take things. About bowel obstruction for the test. No, treatment is not always surgery. Do you ever do drip and suck? What is that? What does drip and suck mean? I don't know what that means. But no, a bowel obstruction, if you gotta operate, you gotta operate. But if it's incomplete, then you stick an NG tube in and you hopefully let them open up. And Emanata, about hemorrhoids, I told you, what's the most common treatment in the world of hemorrhoids? Elastic band ligation. And yes, you operate only in an acute abdomen or if they're not getting better for an obstruction. Very, very good. Can Hirschsprung's disease, does a baby pass meconium? Yes, they could. Yes, they could. For a thyroid nodule, for the test, what do you do first? For the test. FNA. But in real life, someone comes with a thyroid nodule, what would you get first? You'd get an ultrasound. All right? In a non-palpable breast carcinoma, a mammogram is the initial test, and biopsy is diagnostic. Absolutely excellent. Very, very true. Oh, Jeremiah, okay, Jeremiah says something good. Some people, for intussusception, instead of using barium, use air as a contrast agent. Guys, doesn't matter. It depends on the radiologist. Some radiologists want to use air so that they don't risk perforation with barium. Some people do barium. All right? So that's excellent. So sometimes they say for intussusception, they say contrast enema. And contrast enema is two enemas, either barium or air. Very, very good. All right? Oh, Devin, if you've got bladder exstrophy and you're in a rural area, you just put a bag on it. You just don't close it up. That's all. You just don't close it up. Okay? Oh, Amanada, good question. Are gallbladder polyps normally operated here? Gallbladder polyps are usually associated with stone disease. Now, if the gallbladder polyp is greater than 1 centimeter, they're associated with cancer. So the answer to your question, generally speaking, is when people have gallbladder polyps, they usually have symptoms of gallbladder disease. And they usually have gravel, small stones. And so we usually do operate on them. We do operate on them. A painful breast lump, generally speaking, is fibrocystic disease. That's the most common painful breast lump, without any question. Oh, how do adhesions, oh, good question. How do adhesions form when you just, in intussusception? Guys, anytime the bowel is manipulated, anytime you have inflammation, you get adhesions. Because anytime you have inflammation, you get scar tissue. Anywhere in your body. So that's how it forms. Hirschsprung's disease is not usually associated with cystic fibrosis. Not usually. Not usually. Can it be? Sure, but not commonly. Good questions you're asking. Oh my God. Good questions. Oh, no guys, you do not, on the case of abuse, good question, Diamond, you don't inform the patient before. You first tell the nurse. And what will happen is the police will come. And then you talk to them, but you got to get the staff involved because people could get violent. The parents could get violent. I mean it. They can come at you and they could say, you know, what are you doing? Think about that. If you were a parent and you were in the emergency room and all of a sudden you were told that this child was not going to be going home with you, oh my God. You know, people get really angry when it has to do with the kids. In diaphragmatic, it is always hypoplastic lungs. Always, always, always. How do you find good mentors? Guys, you know people who like to answer questions. You just know it. People who are good people, you know it. In ascending cholangitis, ultrasound, yes, is the initial test, and the ERC, Sanya, perfect, is diagnostic and therapeutic. Absolutely perfect. Couldn't say it better myself. Find mentors, guys, while you're typing. Find mentors. You all know people who are role models. Oh, very good. Devin, is there a risk of ERCP-induced pancreatitis? You bet. You bet. Absolutely. And it's one of the risks, but it's low. But it's possible. Absolutely, Devin. ERCP can cause pancreatitis. You got it. Absolutely. Without any question. Good question. Good point. Oh, that you are kind. You know how long it takes me to get... my plane leaves at 6:30 in the morning tomorrow. I don't get to Newfoundland until after 5 o'clock. The mechanism of currant jelly stools. Okay, listen carefully, guys. Guys, listen. You got a piece of ischemic bowel. The red is blood from ischemia. The thickness is mucus from ischemia. The seeds is sloughing of the epithelium from ischemia. So in other words, when you get currant jelly stool, if you sat on it and didn't do nothing, you'd perforate. And currant jelly, that's exactly what, looks like currant jelly. And you're talking to the wrong guy. I didn't know what currant jelly. I don't know who's teaching tomorrow, Devin. I don't know. I come back on Sunday. I don't know who's teaching tomorrow. I don't know. Maybe it's OBGYN. Well, guys, if you have a prostate patient, yeah, you're going to the OR, most likely, without any question. All right? Oh, Evelyn, how does diaphragmatic hernia lead to hypoplastic lungs? If you can tell me that, you'll win the Nobel Prize. I thought, who was working on it? Was Justin working on that? Someone was working on that. I don't know. I wish I knew that. All right. Guys, you have done absolutely phenomenal. I mean it. Arlene, you're sweet. Thank you. And thanks for sending. After I do this, I'm going to look at all your pictures that you sent me and stuff. You guys are wonderful. You have learned a tremendous amount. I truly love, thank you, Mark. I love talking to you guys, and I love the questions you're asking, because not only are they good medical questions, they're good doctor questions. All right, so guys, you have a great evening. Relax. I will see you again on Sunday. And remember the things that I've taught you, and remember the stories that I taught you, because they help you be a great physician. All right, guys. All right. I will see you on Sunday. Good night. You take it easy. All right. You guys are absolutely the best. Good night.